Oh. Wow.
No, I wouldn't be able to tell you that.
I
Are these all?
Those are not, I don't think so. But these are all custom, I mean, they're all custom. For every case that you send, it's going to be a custom protocol.
I see. So this is to be returned back to you?
Those are, I mean, I guess you can keep them. I don't have any need for them. I'm sure they can make copies of it.
I see. Kind of one of each.
Oh, so you're going to have to, essentially we have everyone sharing. So we'll do just regular implant placement first, and then we'll kind of switch to sinus again. We're good? All right. Let's get started. First, housekeeping. If you guys need to use the restroom, you can either walk all the way around or you can go straight through that door. Just don't be surprised when you open that door. There's a desk there with all the AV guy sitting there. There's also another restroom if you go out the building, if that one's occupied, all the way down the hall as well, if we need to go there. The plan is to lecture in the morning, talk about everything that true abutment and URIS can offer. So I'm going to go really, really quickly over how we restore stuff with true abutment in my office. Then we're going to kind of focus in on single ones and twosies implants. And then the latter half of the lecture will kind of focus on sinus bumps, internal sinus bumps, what we look for to make sure it's a good case to do it pretty predictably with the URIS Pylon sinus bump kit. And then in the afternoon, we'll have lunch and then go ahead and do hands-on stuff. So really everything on your desk will be mainly for this afternoon when we start talking about that. And I'll demonstrate it all up here up front, and then we'll kind of turn it over to you. And everything's really split on your tables for you to share. There's a regular guided implant kit, and then there's the sinus implant kit as well, and I'll walk everyone through that when we get to that point. But where's my phone? I saw something online that kind of resonated with me. And I think it was actually, I don't know if any of you follow Dr. Appa, who's literally flies all over the world to do restorative cases. He has offices in LA, New York, and Dubai. But this is kind of what he posted like 2 days ago. Is if you're not failing, you're not pushing your limits. And if you're not pushing your limits, you're not maximizing your potential. And I think for me, I'm always trying to look for some new procedure, something new to learn, to kind of add to what we can provide our patients. And failing is something that I think as dentists we don't talk about much, but it happens, and I think we need to learn from our failures and accept them. Not every single implant I've ever done has integrated. We've had some complications, and it's learning from those cases and growing from them and knowing hopefully how to avoid them. Some of them I don't think you're going to be able to avoid, because that's why implants integrate 90 to 95% of the time. There's going to be that 5 or 10% where things don't go according to plan. So, but hopefully each and every one of you take something out of this today and kind of add it to your repertoire of procedures that you can provide your patients. So this is just a quick little video. Is it playing? That I'm just going to have you guys watch.
Is this supposed to have sound?
No, there's no sound.
Okay.
So what was the answer?
12.
12? 13? Close enough. But did you see the moonwalking bear? Just watch closely now. Don't look at the ball. Just watch through the middle here. See him?
Yeah.
So the reason I do that is I hope, just from my present today, my goal is for you guys to take one thing back to see things differently. that if you can see things differently, or if your mind knows to look for things, you can do things differently and change how we treat patients to get the best optimal protocols and the best steps to set us up for success. So why do I do things guided, and why do I have the technology that I have? It's to avoid mistakes like that. That's a patient that came into my office as a new patient consult, and he thought his implant was doing just great. We now had he came in, or he initially, I guess I might need a new battery. With just a one-tooth problem, essentially he wanted a one-tooth problem fixed. Now we have a three-tooth problem. We have this tooth we already had to take out and graft because it was now mobile. This tooth, the previous dentist hit the apex, and now we're having to deal with deciding between trying to save this tooth with an endo, or are we going to be now having to deal with a 3-implant problem. Where if we were able to do it guided and knew what we were getting into by looking at the bone in all 3 dimensions, we could have just dealt with a one-tooth problem. So why are we here today, and why do I do things guided? One, I want to do it from a crown down approach. Implants are truly a prosthetic-driven treatment. So I want to look at and design my crown first, where I want it to go, and then start thinking about where I want my implant to go. So for me, that's scanning the patient up with a full arch scan digitally, combining that STL file with the cone beam data, having my crown where I want it, and then figuring out if I'm going to can I do a screw retain crown? If I can't, do I need to do a custom abutment, and have all of that going into it, knowing what we're going to be able to treatment plan the patient. If I'm not going to be able to get in the right spot, do I need to do some grafting first? Is it a ridge augmentation? Is it a sinus lift? Is it something else? But I have all of that knowledge going forward to kind of set my patient up for success. The other reason that I love URIS is they have the fully guided, fully timed, keyless implant placement. That's a lot of fullies in there. And what does that truly mean? It means that the fully guided means from start to finish, when we're talking about URIS implants here, everything goes through the guide. So all the initial osteotomies and also the placement. There are some guided systems where then you still have to place the implant free-handed at the end. Fully timed means I know where the hex is going to line up, so I can have everything prosthetically essentially created for that case before we get started. And I'm going to show a case how we used to do it way back when, like 3 years ago, and now how we can do it because we have the capability of also knowing where that hex is going to line up, and all our prosthetic pieces can be fabricated before we even get started. And then we're going to talk about keyless, which a lot of guided systems, you have keys and you're having to put the guide in, then you're putting a key in, then you're putting your drill in, and you're like, there's like 18 things on a patient that opens all of like 2 fingers. Like you can't get all that stuff in there. So I like it not having essentially the additional keys. And the exact same thing goes for the internal sinus bumps. How I was taught was essentially to do it guided, do my first initial osteotomy guided, and then do all the additional steps, all the sinus bumps, free-handed. And you're kind of guessing as you're going along. You may not have your angle right all the way along. We now have a fully integrated approach to placing, doing internal sinus bumps, fully guided, keyless, and I forgot fully timed as well. So you can do everything as well. So you can have your, if you want to do custom healers, all that done. If you're going to be going and doing an immediate load, you can have that temporary done as well. So this is a very intimate setting. I know we have some people online, but I like to get a feel for where everyone is in kind of their journey. I will introduce kind of a little bit more about my background last, but you can see I have like every dental CEREC toy imaginable. I don't know if you guys want to go ahead and start kind of where you are, what dental toys do you have, if you have any, and then kind of where you are in your implant journey. What type of implants are you placing, if you are placing, and if you're not, then like anything that you're hoping to learn from today. Yeah, go for it, Bruce. Sorry to put you on the spot.
And when SC Rush 2000, I practice currently in Chino. I played some implants, not that many, and I just recently bought the kit from here. So this is my second time, so I'm trying to learn more. That's why.
Doing everything guided, non-guided?
Guided.
Okay.
I learned freehand, but I feel more comfortable if I were to have something guided, so I can be more confident.
Perfect. Robert?
I practice in Irvine, right down the street, and I probably play maybe 2 or 3 implants a week on average. I've been placing implants for 20 years, 25 years. But
Everything's the same?
everything, so yeah, I'm just going through my old stuff. Yeah, no, I started with the Nobel, which was only 8 pounds back then, and I worked my way through the whole system. I'm heavily into the CRF system. I do have Galileo, that's my CBCT for years. Probably don't utilize it as well as I should, as far as, and, I get lazy and, I'm not placing a whole lot of guided cases anymore. I used to do more with full large reports, but otherwise, and I would have to send that out back in the day.
Yeah.
Send it
To another, yeah.
Sweden, I think it was, Switzerland, I don't remember. And, slowly trying to get back into guided, that's why I'm here.
Yeah.
But yeah,
So one of the things that, I don't know, we're going to go down some tangents today, and I think where we go down tangents are actually the great learning opportunities, so I'm going to just reminded me of something. Are you taking CBCTs on all your patients, or just your implant patients?
just my implant.
Okay. Why?
Well, I don't know, it's just a habit,
Okay.
I don't utilize that, I don't utilize that thing.
Yeah.
I should be taking it on every patient.
I would completely agree with you. I think it is the best diagnostic tool I've ever introduced into my practice. The amount of failing root canals you see on that thing, like I see radiolucencies light up all the time. In my office, if I see a radiolucency or a periapical pathosis, to me, I don't really care what size it is. Maybe if they just had the endo done 6 or 12 months ago. But to me, it's like incipient caries, especially if we're talking about implants, because I'd rather catch that abscess when it's small and when we can predictably graft it, if we're looking at going down the implant pathway, rather than it waiting and carefully waiting and watching until it blows up and all of a sudden buccal plates are gone or palatal plates are gone, or it just makes it much, much more challenging. So I kind of encourage everyone that if you start seeing stuff like that, don't watch and wait. I don't think any of us would watch and wait something that's broken the DEJ. We go in there and we do a conservative restoration. But I highly recommend just going in there and trying to get that stuff out of there, or send them for a retreat if it's something obvious where they've missed an MB2, or if it just looks like a crappy root canal done, go retreat it. It gives me the opportunity to give I think my patients the best treatment out there. So if you have a CBCT, I don't charge any extra. I include it in my FMX fee because I see so much dental work that I can then give my patients the opportunity to say yes. So I encourage you, every FMX, that being part of your protocol moving forward. Because I know it also will give you the pano if you just want to look at the pano. It may take you an extra couple minutes, but you do see a ton of dentistry. So, I'm sorry to interrupt you. Just one of the tangents that we'll go down, and please interrupt me today, because I think, like I said, those tangents, I think are learning opportunities. So, is there anything else you wanted to add?
No, that's it.
Okay. Go ahead.
I'm from Maryland, 85. My wife, she's a prostitute.
Okay.
We pretty much semi-retired. We moved here about 6 years ago. I don't do that much implant like I used to anymore. But I just like to keep up with everything. I have placed one URIS implant on one of my patients about 2 years ago.
Okay.
Successfully.
Good, it's still in there. Are you guys traditional, digital, cone beam?
Where are we kind
Well,
of?
at that time, we have Panorex, and if we need to, we have Kundim service combined scan, we are not planning for us.
Okay.
We also have surgeons come in and do some major case for us, back
Yeah.
in Virginia.
Okay.
You know, we used to have 2 offices back in Virginia, but since basically 6 years now, we left and we come here kind of somewhere retired.
Okay. Cool.
I work in part-time Long Beach, so I drag him along.
You guys work together?
Yeah, he told me to come here. So.
Okay. Cool. Hi. Either one of you?
So I'm Ku Kareemi. I graduated in 2014 at Loma Linda, and my dad's a dentist. He's in Fresno, and he always told me to go place implants, and I never did. I never really was comfortable with it. But Dr. Ho told me, hey, just come here and just check it out. I've done one of these before, but we just did the class, and then that's it. We never really did anything.
The next
more
step.
than that, yeah. So, but now I'm like, you know, I want to start somewhere because I'd rather do an implant than a bridge. You know, it's just more optimal,
Yep.
better for the patient. Everybody's happy. So.
My office manager always yells at me because I really don't give him an option of restoring it with a bridge anymore.
Yeah.
And we go back and forth all the time, and I'm like, I really don't want to do them because I think it's long-term wise we're going to create more harm than good. But go ahead.
I'm Pete Rich. I practice in San Diego. Actually, just started placing implants this past year. I've only done fully guided. I did learn freehand with the implants on Rose Course Regard, and I've been a true button user for a couple of years now. And I'm in a heavy CAD/CAM practice, so I use a lot of plant back assistance.
Okay. Can you give me that laser pointer or one that will? We could try the battery too. Sorry. Go ahead.
Oh, wait.
You're gonna have to take tape off.
My name is America, and I've been practicing for 26 years, and I've been doing implants for, I don't know, 8 years. At the beginning, I was doing a mobile care, and now I do Bio Horizon. And I used to have 2 practices, one in Laguna Beach and one in Anaheim. After 26 years, I left Laguna Beach and I'm just in Anaheim. But I do freehand.
Okay.
I would like to try
The guided?
Yes.
I don't know how long does it typically take you to place an implant?
It's single implant,
Yeah.
less than an hour.
Okay.
But I always fly.
So do I.
Yeah, always fly.
And we'll talk about that in a little bit.
Oh yeah, I took the classes with Dr. Nish,
Mm-hmm.
Frank Nish, and I just followed pretty much what he used to do, flapping on the time.
I bet you with guided you can probably get down to like under a half hour.
Okay.
So.
My name is Michelle Skinner. I practice in Culver City. I have placed implants, but I don't currently in my practice.
Why?
Why? I just have a surgery job.
Okay. Cool. We're just giving quick introductions.
Oh, okay, sorry.
What do you? No worries.
My name is James. I graduated in 2000, so in a few years. I started with mobile care. Did the Smiley Community Residency back in 2003. Since then, I've used a couple of Korean brands like Dentist and Implant.
Okay.
I did mostly freehand. I'm starting to learn the new technology. I'm old school, so I think in the future I want to get into just more precise placement and maybe quicker too.
Okay. Cool. So a little bit about myself is I have a bunch of dental technology, and I've kind of leveraged that to start adding additional procedures into my office. We jumped into the Omnicam world probably 7 or 8 years ago, and then slowly started adding clear aligner therapy, sleep, and then I've probably 2 years ago now have started placing implants. So you guys have been doing it a lot longer than I have. Perfect. But I got into the digital world starting in dental school. And I tell this story on why. Is that in dental school, I was on emergency clinic. I think I was in 4th year. We had our really cool pagers. I got my like buzz on the pager, and I walked up to the counter, and they gave me a chart. And I think it was, I don't remember the guy's name. It was like Joe Smith. And I turn around and I call out Joe Smith. So I have not looked at the chart yet. And a guy goes here, and he's in a wheelchair. And you know like those cartoons where you see like full arm cast, and then like 2 leg casts, and he's just sitting there in a wheelchair like that. And I'm like, what can I do for you today? And he's like, I broke my temporary. And I was like, I got this. I'm a 4th year dental student. I can handle a temporary. So we wheel him back to the operatory. Luckily, I'm a big enough guy that he has no help. There's no caretakers with him. I don't know how we got there. But we get him into the chair, and I go, what happened to you? Like referring to his arms. And he goes, I am a janitor at the hospital at Penn. And I was up on a ladder, and one of the gurneys came around the corner and essentially knocked the ladder from out underneath me, and I fell. And I broke like several bones in his body. I've been in different rehab facilities in the hospital for a while. But I'm here today. I finally could get out and move around, and I broke my temporary. Can you fix it? And I go, sure, like, no problem. So we sit him down, lean him back, and I look, and it's not just a single tooth temporary. It's not like a quadrant of temporaries. It's a full mouth rehab of temporaries. And I'm like, I would probably be crapping my pants now if that walked into my office. Like, I have no records to go off of as well. Like, there's some that are like serviceable where there's cracks, and I start putting like the pieces back together. But I don't know how long that would take you to like traditionally like block, carve up like a full arch of like temporaries. But I was like, this is gonna be a fun day. So like, it took us probably 6 or 7 hours, which was a great learning experience. He was a great patient, was super like patient with me and kind. And at the end of the day, he goes, I need to go to the bathroom. And there's no one to help me. You're gonna have to do it. And he's like, and we need to move quick. So like I get him up out of the chair and I get him into the wheelchair, and he's like, oh, by the way, you need to bring cups. What cups do we have access to in the dental field? Like 2 ounces, maybe 3 ounces tops. So I'm pushing him along. I see the cups and I grab him, and we're like off to the bathroom. And he goes, you're gonna have to help me here. And I'm thinking to myself, I'm in dental school for a reason. I did not go to med school. I did not want to be doing this. So like we get everything in order, and he's like, hand me cup number 1. So I hand him cup number 1, and he fills it up in like a half a second. And then he gives it to me, and now I'm holding a cup of warm urine. I don't want to be ever holding that, including my own. And I just like chuck it, and I think I threw it in the trash can or the sink. And I give him cup number 2. That takes him about 2 seconds, and now we have this back and forth, going back and forth with warm cups of urine and then we run out of cups. There's only like 4 cups that I bring. So now I'm retrieving used cups and giving them back to him. We're good to go. It probably felt like 5 minutes. It was probably like a minute. And he gives me the last cup and then decides to spill it all over my arm. At that moment, I knew when I could do single visit dentistry and never have to do a temporary again, I would do that as soon as possible. So that's why I jumped into the CEREC world as soon as I could. And now why we have so many of these toys, because they're constantly being used every single day. I have assistant scanning, I have my associate scanning, I'm scanning. I'm almost thinking about adding a 3rd one at this point because we're using it so much. I want to get to a point where every new patient is getting a digital scan so we can start opening up more conversations and getting some co-diagnosis with it. So that was the first edition. And then this is, I have the OrthoFos, but the Galileo system that integrates with my CEREC, so I can be doing these procedures in-house a lot of the times. But as soon as we get to more than 1 unit, I need someone else to be making those guides for me at this point. It takes a lot of time and effort to do some of these multi-unit cases, some of these sinus bumps that I don't want to really plan for. And that's why I've turned it over to the true abutment and URIS to allow me to do that. And we'll kind of walk through the protocols here. But as you were saying, both your dad was a dentist. Both my parents were dentists. And that's me in their office for almost 40 plus years ago. So we worked together for a couple years. And then for the first couple years, it was great. I was just getting my feet wet, figuring out how to get comfortable talking to patients, doing MODs, doing crowns, doing inlays, doing quadrants every once in a while, maybe 1 or 2 over those first 5 or 6 years of like really aesthetic cases. But they kind of trained me with the mentality of like a drill and fill dentist. And after about year 4 and 5, I was ready to kind of take a step beyond that and kind of start implementing some of these new techniques that we're going to be talking about today. And I got a little bit frustrated and I felt kind of handcuffed. And it wasn't until they retired where I could really put my stamp onto the practice and kind of bring in all of these additional tools that have allowed me to, we're doubling if not tripling the practice since they've retired. It's been an amazing ride. I didn't have it, but my little guy is turning 4 on a week from tomorrow. And I think I took that picture at like 3.5 or 4, so we just took a picture of him in the exact same spot in the office. That'll be fun. Yeah, not quite the same phone. The computer system looks a little bit different. All of this looks different as well. The fake flowers in the background, we've modernized it and redone it. But yeah, I definitely, got my feet wet and learned how to do kind of the business operations side. I was in there in high school when they brought the computers on and was kind of implementing all the insurance and turning that over. But yeah, it does look a little bit different now. And that's kind of what I said is I had to kind of get through that barrier, that ceiling to kind of really open up my eyes to what dentistry can do. It's not the every tooth needs an MODBL composite. We can start doing crowns and quadrants, and we're doing that routinely. And this kind of is another tangent that as we're adding more of these services and I'm becoming trained, I'm almost becoming like a specialist in the office. And those are more services that I'm kind of getting funneled into. And that allows my associate to come in and start adding additional procedures as well. So her part of the practice is growing by leaps and bounds as well, because I'm also focusing on more. She's growing it independently, but I kind of call it the trickle-down effect, where you're doing more specialized procedures. Some of the MODs and quadrants are things that she takes on now. She's doing anterior 6s or 8s pretty routinely without my needing to get involved. So, and that kind of brings me to kind of this very, very simple equation. If I want each of you to put like your dental CEO or CFO hat, and how I looked at it with my parents' mentality to how I look at this kind of equation now. I don't know, I don't want to call on you, but if anyone wants, like, what do you think is the first thing that most dentists look at when they look at this? How do they want to fix that? How do you want to increase the ultimate profit? Decreases overhead is 99% of the time the answer I get. It's because it's the easy thing to do. It's something that it's usually supplies. So I always look at my supplies and how do we save money. So that's the first thing. I don't know if you guys have realized what the cost of a box of gloves was before the pandemic. What, $4, $5? I don't know if you wanted to look and see what it was during the middle of the pandemic, but it was getting up to like 15, 16, 20. It's come down a little bit, but it's still expensive. I don't know, like trying to find masks, that was another endeavor. So given the scenarios, it's very, very difficult to decrease your overhead right now. I think yeah. Exactly. And then I often try to like keep costs down with my team. If you're trying to hire anyone right now, good luck. It's definitely, the pendulum has shifted towards them. Like, I've been trying to hire an assistant for 6 months, and if I get, like, they're almost, if they show up for their interview, they're essentially hired at that point. Because I've probably set up 20 interviews, and I've probably had 5 actually show up from conversations on the phone, and they're asking for a lot of money at this point. It's not stuff that I'm used to. But I realize that if you find that right one and start investing in your team and paying them more, they can take over a lot of the time and the onus on them to do a lot of things. Like, I really don't scan anymore. I have a couple that I'm on the verge of letting them design CEREC crowns and essentially prep and being able to walk away and let them take that over so I can focus more time on stuff they can't do, setting up implant guides, talking to patients about conversions for ortho or other things that we can offer. So I did the exact same thing, and I think that's what my parents tried to do, and I think there's only so much drill and fill dentistry that we can do right now. We also have, if we talk about revenue, there's only so much we can do, and there's only so much that we can really charge if you're a traditional, I think, PPO office right now. Reimbursements and third-party payers are essentially keeping that at the same rate, if not decreasing them. So I think we as dentists, if you're in that drill and fill mentality, your revenue's going down and your overhead's going up. That's not the combination that we want. What I started to do is look at how we could start increasing our revenue. We could try to charge more for those patients that are fee for service. That's one option. One option was to start bringing stuff in-house that we used to refer out. And that started with the clear aligner therapies, sleep. Those are all revenue sources that really aren't, that third-party payers really haven't put a cap on at this point, and we can charge what I think we're entitled to charge. So CEREC and the cone beam allowed me to essentially jump ahead, and all that training that all the specialists and the oral surgeons and the prosthodontists and the periodontists with all of their hand skills, I can essentially skipped all of that training because I'm relying on the technology that's out there to get these implants placed in the right spot. And when we're talking about implants, it's not a one-ticket item revenue generator. It's the extractions, it's the bone grafting, it's the implants, and you're going to see what that trajectory did to my practice. And then there's 3 things that I've kind of learned over the last couple years getting into the digital space. And it's kind of these 3 guiding principles. And I think we talked about it already, but the eyes don't see what the mind doesn't know. It's looking for things different, getting educated. Look, now that you actually know that the dancing bear, the moonwalking bear is going to go off across the screen, next time you see that video, you're going to know what to look for. But I heavily invested in continuing education. And it wasn't the continuing education where I was like learning about bonding agents and etches and like the stuff that you can go down that rabbit hole. It was really looking at starting to adding different services, implant, sleep, those kind of 3 things. The best investment you can make is an investment in yourself, in your team, in your office. I know it's kind of controversial when I start bringing up dental school tuition, but it's like, okay, $100,000 to $150,000 right now. If we look at it times 4, we're looking at probably $400,000 to $500,000 when new grads are coming out. But looking at it just from an investment perspective, let's say worst case scenario, it's $500,000 that these kids are coming out with. I'm pretty confident any newbie full-time, if they're working 5 days a week full-time, can probably be making $100,000 a year. If we're looking at that just as a return on your investment, that's a 20% return on your investment. I think any of us would take that 20% return year over year if we're looking at it just like if we're investing in stocks or real estate or something like that. But when you start adding additional procedures, that investment in your education, whether it be CE, whether it be events like this that are free, so really your return on is infinite today, that skill that you're learning can be repeated over and over and over and over and over again. So that return on your investment is infinite. when you start getting comfortable placing implants or doing any procedure that you haven't done in the past. The other thing that I often look at is just an investment in my team. And I kind of look at it two ways. One, I looked at it as when I started bringing this technology on, it started weeding the people out that I think were anchors in my practice. People that didn't want to be part of me challenging them and moving them forward. It kind of got rid of those people and they decided to leave, or we came to a mutual decision where it just isn't going to be working out for you. It also allowed those individuals who were looking to grow and learn and improve themselves, they took off and started sprinting with some of the technology that we worked in the office. So now a lot of the stuff behind the scenes, the finishing, the polishing of the crowns, surgical guides, once I approve it, they can take it off and start running these things. So I highly encourage everyone to start really investing in the CE, investing in themselves to kind of truly change your practice. And I think this is the hardest thing that dentists deal with, is how do we eventually do that new procedure? How do we do that first implant that you were kind of talking about in the beginning? How do we get over that hurdle? And one of the things that I learned is whenever I do a new procedure in the office, I'm doing it for free. And I did my first 5 implants completely for free. I picked those patients that probably couldn't afford it. I asked them to do a 5-star review. I had my reps, or I had another dentist who had done it before in the office with me. And the patients were completely aware of that. And it was an amazing learning experience being able to freely talk in front of the patient, being able to learn all of those things. So you can be, I think, a little bit short-sighted if you're trying to get every penny out of the patient, especially when you're doing something for the first time. To me, it's an invaluable learning experience, having that open communication and learning. And I think it also takes some pressure off your assistants. They're nervous as well. They don't know what to do when they're setting up something for the first time. And we're able to do it for free for 5 or 6 times. By the 5th or 6th time, they know what they're doing and they can have everything set up and they can breathe. And that tension just kind of eases away. And what is a 5-star review worth to you? Just ask them. You're giving them a $2,000, $3,000, $4,000 procedure if they're paying kind of fee-for-service fees for free. I think that's the least that you could ask for them. So I jumped ahead of myself here, but this is why I like cone beams. Is I think we can all safe to say that the mom lion isn't biting the baby lion's head off. But that's what it looks like from this picture. To me, this is a prime example of what a PA shows us. It doesn't show us much. We have to assume that the baby lion's okay, but having the three dimensions allow us to predictably place implants very, very safely and very, very conservatively. And we also know if you're not comfortable doing ridge augmentations or sinus bumps or lateral sinus bumps, we know what cases that we need to refer out and to avoid. It kind of brings me, I think you said you have a specialist in your office. So do I. He was getting to, and why I finally, as you can tell, I've added all the other procedures first and then jumped into implants last. And part of that is that I was uncomfortable doing that. I was a little bit scared, and I kind of had that safety net of the periodontist comes into my office. But as I was looking at his schedule, he was starting to get, he comes in once a week, he was starting to get booked 3, 4, 5, 6, 7 weeks out. And I was like, I need to start doing those procedures so I could take that off his plate. It also allows him, he always says a single implant is his favorite thing to do because it's like us doing an occlusal amalgam. But me taking that on allowed him to then for him to focus in on right now the full arch stuff, the lateral sinus bumps. And really get him to be utilizing the degree and the specialty that he has to the full capabilities. So And it's also a great learning opportunity to have him there on some cases that I'm still not sure about on how to handle. Investing in yourself, like I said, it's kind of that never-ending return on your investment where you get all of that growth and potential. And then getting uncomfortable, it is, I think the hardest thing for dentists to do is to kind of face failure. And yes, they are going to happen, but those are learning cases. And the failure is where you learn the most, and that's where you get pushed. And I think that's where kind of the Dr. Appa quote resonated with me, that it's okay to fail. We don't talk about it, but it happens to each and every one of us. And the synergy. The 1 + 1 is greater than the sum of the parts, or 1 + 1 is greater than 2. Is when I make decisions now, if I feel uncomfortable, that resonates with me that it's something I probably should be doing. If I see it as an investment in myself and my team, it's something that I definitely now, if it hits both of those points, and if it's something that's challenging me and trying to educate me, I know that it's something I needed to do. When I saw CEREC and then paired it with the cone beam, that 1 + 1 isn't 2, it's 1 + 1 equals 10. So I highly encourage, if you guys don't have that, to kind of get into that. And this is kind of how it's changed my practice. I joke now, my practice was really divided into 2 categories. I call it BC before CEREC, and then AD after going digital. 2016 was the year that we decided to jump in that digital world, and I had to make a decision whether I was just going to kind of tiptoe into that world and kind of go into the shallow end, or go ahead and kind of do the cannonball in the deep end of the pool. I did the cannonball in the deep end of the pool. We got the CEREC machine, and I kind of immersed myself in the continuing education of just restoring quadrants and restoring implants. And true abutment is the critical piece in the CEREC world if you want to be restoring implants in-house. It was truly a game changer. And we'll talk very, very briefly about that in like the next 5 minutes. And that was kind of year 1, where I was finally like the drill and fill. We still had a little bit, but we were offering our patients more services and the opportunity to do same-day dentistry. So we finally broke that kind of $1.2 million platform, and I was like, hallelujah. It only took me 8 or 9 years to get there. But then we started adding the additional services like Sure Smile or clear aligner therapy. We then added the cone beam and started offering patients sleep, sleep testing, and then you can start to see like this rapid growth as soon as we started adding implants. So if you're not doing it, that was where the major growth happened. And in 2020, it was like all of the things either went right or wrong, depending on your view of things. But we had this like hockey stick growth where we really started doing extractions and implants, and it truly saved my practice. During those 2 months that we were shut down, that's really all I was doing when patients were coming in with toothaches or broken teeth. We were really doing extractions and bone grafting, and then setting them up for success later on when we could then do implants. So I get to add to this graph now. We actually just crossed the $2 million platform in revenue yesterday. So we're still kind of growing. I don't think we're going to get as much vertical this year, but still definitely growing. I have myself and I have an associate. And then I have my surgeon that comes in. So my associate's there 3 days a week. I work like a four-day week schedule, and then I have the surgeon that comes in 1 day a week. The other thing that I've learned as well is trying, when you start keeping stuff in-house, is how many more patients say yes. Like, it was mind-boggling to me. They don't like getting referred out. Patients got lost in that transition. But when you can talk about, yes, we can do it here, we can walk you through that A to Z process of start to finish, and really having one flat fee for implants from start to finish. So bundling all of those services together: extraction, bone graft, implant, prefab abutment, custom abutment. You know going in and when you're planning these cases what it's going to be. And having one flat fee it made patients say yes. Now I break it up into chunks, but having that one flat fee, I don't have broken it down by line item when we start treatment planning. It's a one flat fee and then breaking it down into payments. The conversion starts to increase significantly. So that was kind of my very brief story. Let's start talking about true abutment and why I love working with true abutment and URIS. So there is a volume that'll kick in hopefully like 2 seconds.
The why was born out of pain. It was never an academic or commercial exercise. It was born out of a time in my life many years ago, 10 years ago, where I had lost my passion for what I was doing. I owned my own small business. I was living the American dream. Superficially, my life was fantastic. And yet, I didn't want to wake up and do it again. And I was embarrassed by that. Who am I to complain about my life? My life seemed perfect, and yet I hated it. And so I kept it to myself. Every ounce of my being, all the energy that I had was invested in pretending that I was happier, more successful, and more in control than I felt. And it was debilitating, quite frankly. Strange things start to happen when you put yourself in that cycle and the stress starts to build. You start to become paranoid. So for example, I was convinced that my employees hated me. I didn't go out much, and it was really a bad time. And it wasn't until a friend of mine came to me concerned that I wasn't acting myself and basically offered me nothing more than moral support. Whatever you need, I got your back, I'm worried about you. And it was that simple act that gave me the courage to face my own problem. And it was that simple act that gave me the courage to seek out a solution, to go back to the way I used to feel, to be passionate about something again. There was a confluence of events, and I made this discovery that every single organization on the planet, even our own careers, always function on the same 3 levels: what we do, how we do it, and why we do it. And it was based on the biology of human decision-making. It wasn't some highfalutin management theory. It was based on brain stuff. And I realized I knew what I did and was good at it. And I knew how I did it. I could tell you what was different or special about the way I did things, but I couldn't tell you why I was doing it. That was the missing piece. You have to have all 3. I became obsessed with this thing called the why. I figured out how to find my why, and it restored my passion to levels I had never experienced before. And more importantly, I figured out how to help others find theirs. And I did what anyone would do. When you discover something beautiful, you share it with your friends. And my friends started making crazy life changes themselves. And they started finding happiness and passion that they'd never experienced before. It was me solving my own problem that happened to help others solve it for them too. And people just kept inviting me, and I just kept saying yes. I was making huge decisions that were really easy to make. Like I shut down my office and started over again because I realized the business I had built was so inconsistent with my why. All my friends thought I went out of business and they were worried about me. It was the easiest decision I ever made. In other words, when you know your why, the filter is clear. It's not like there are options. The option is obvious. There's only one option. Share, give, inspire. And everything that I've achieved, any success that I've enjoyed, has all been 100% because of the gracious, just amazing generosity of people around me. My friends, my colleagues, people who just believe what I believe. They're the ones who either introduced me to others or took a risk or said, let me try that, or bought a book or watched a TED Talk, or more importantly, sent it to somebody else because they thought they would be inspired by it. For all of the things that I've done over the past decade, I still feel like I'm at the beginning. I've been saying it for 10 years. When everybody says to me, congratulations on X, Y, or Z, my answer is always the same. Tip of the iceberg. And I think that's what keeps me inspired, which is, for me, it's a journey. I'm on the right path. I'm walking past the right mile markers. In other words, I know I'm making progress to the vision that I have to build this world in which the vast majority of people wake up every single morning, inspired to go to work, feel safe when they're there, returning home at the end of the day fulfilled by the work that they do. When I started the race, I ran by myself, and it's lonely. lonely. And now I got like 1,000 people to the left and 1,000 people to the right and 1,000 people behind me. And I look around, I'm like, yep, we're gonna change the world. We're gonna change the world. There you go.
I don't know if it resonated with you on kind of, we all do the same thing, we fix people's teeth. It's just how we do it is all different. The why for me is when I started going into the kind of the digital space, it was fun to me. And I wanted to start leveraging that fun that we were having in the practice to really kind of truly grow and move forward. And kind of that why is that we decided to become a digital dental practice that it kind of allowed me to do what I call the 3 E's. Expand my services, improve my office efficiencies on how we perform procedures, and then create a dynamite patient experience. So kind of the patient experience, my efficiencies, and then expand my services were the 3 E's. True abutment, or why they're here, is if you're in the digital space, they truly figure out all of the things that like the problems that we run into, and they fix it before we even realized that it needed to be fixed, especially with the implant side. So they're always literally one step ahead of us, or they at least are listening to us, where we've asked other companies to make fixes and simplify things. Other companies haven't. True Abutment has kind of stepped up to the plate and did that. And this is where I finally got my first introduction with True Abutment and kind of restoring this particular implant. I was at a CDOCS level 3 course, which tells you how to restore implants at the time with their workflow. So you can do everything in-house, mill the crown on this particular tie base. The problem with tie bases is they come in stock sizes. And with kind of the modern protocols of putting the implant 1 millimeter subcrestal and having a tie base that is only 1 millimeter tall, you start running into the bone here. And they taught me this in the class, and I just decided not to listen or forgot it. And this is, I think, my first or second implant restoration. I tried to do a CEREC, and it wouldn't fit. In this particular case, it's 2 reasons. One is just a narrow area, so it can't get into that spot. But 2, it's slightly subcrestal, and this is a failure. Or I think of it as a learning opportunity, so I won't make that mistake again. But it's also an opportunity for companies to come into the marketplace where we can start getting tie bases that are 1, 2, 3, and 4 millimeters above the platform of the implant, and that's what True Abutment did. So that's kind of what we had to do at the time. We had to go back and get a custom abutment, get that fabricated, and get that implant and screw retained in place. And this is kind of the first thing that, like I said, opened my eyes to what True Abutment offered. And they are able to come out with different heights of these tie bases, so we can restore these particular cases in-house. So we can put the scan body in there. That scan body essentially correlates to the different heights. And if any of you guys are not restoring them yet in-house, there are all these different pieces and kits over on that table over there. It does 2 things. One, it avoids the crestal bone, so we can fully get that implant abutment engaged. And 2, it also just improves the ratio of the height of the tie base and the crown to get as much support as possible. So if it's a really tall crown or placed really, really deep, we can get the GH4 bone. My workhorse is GH2s, but we constantly are using GH3s and 4s. This I use probably 80% of the time. So this is a great restorative option. The other thing that they then got one step ahead of us again is if I get into it and I realize that I can't, because of the screw access channel, I can't get a screw retain restoration in there, the current protocols, sorry, I just realized my computer's about to die. For some reason, it's not charging. You guys have another outlet somewhere? Or let me see. I don't know if that's going to unplug anything. No, it's not charging. There we go. Cool. So if I need to go from a screw retained restoration and I have to go to a custom abutment, I don't have to take off the scan body. I got it working. Okay. Just the outlet back there wasn't working. I can then go ahead and use that same scan, that digital impression, send it to True Abutment, and they'll fabricate a custom abutment for me. Or if we want to go one step further, if you want to do a full titanium crown, they can do that as well. Or if you want to have them do an angulated screw channel restoration, and you're going to have something in the front, you can do that as well with this same scan body. I don't have to have, and it's happened to me before, where I've essentially thought it was going to be routine. I thought I could do a screw retain restoration, sent the patient home, and then all of a sudden they've left and I realized they couldn't do it, and then I would have to have them back and then put on a different scan body to get that made. This workflow allows the same scan body. You just have to make sure you tell the lab or tell True Abutment when you send it to them which particular scan body you sent, GH1, 2, 3, or 4, because that will then determine the height of that restoration. And you just, in Sirona Connect or that portal that I send to them, just make sure you write GH1, 2, 3, or 4.
For the non-CERT doctors, they work the same exact way for our non-CERT scan bodies, the regular scan bodies. So.
Are you sending them, are they sending you the file, the crown file back, or are you doing the file?
So you can do it both ways.
What are you doing? You're scanning it after you debug the back? You're assessing, or you're just sending a file?
So then what he's getting to is that with this custom abutment, you then get sent a core file back, which is an exact replica of your model that you sent them with the custom abutment in that particular model. I then can marginate that model and just pretend like that core file is my prepped crown and design a crown off of that. It takes them about 4 or 5 days to fabricate that. I have the crown waiting in my office. I check the fit, which it's usually impeccable, and then we have that screw retained restoration. And it's very, very affordable. I don't know the exact number, 150, 60 bucks to have that custom titanium abutment made. And then you place the crown that you're making in-house in my particular case, and you can have a very, very economical restoration that I think if you're sending it out to any lab, you're talking about 300, 400, 500, 600 bucks. And that's the same thing that goes back with just the tie bases. Tie bases run with them from anywhere from 65, I think, to 95, depending on the implant. And then the screw, then my restoration that I make in-house, you're talking about 150 bucks to have a screw retained restoration. I think that's where, when I was just on the restorative side of what Sarah can do, that was a complete game changer. So if you're not doing that, I highly encourage it. And if you want to learn about those protocols, they're actually offering a very similar class to this, but focused in on just restorations on September 17th, right in this room. So if that's something you're not doing, I highly encourage you to check it out with a friend of mine, Dr. Hagen. Did I answer your question?
Yeah, I just
Okay.
don't really personally do it.
Yeah. So if you don't, you can always send it to your lab of choice. And based off of that scan body, essentially it's just an extra step. They'll send it to True Abutment. True Abutment sends it back to the lab, and then the lab sends it to you. You can do that as well. You can do the angulated screw channels. Same thing. In this particular case, you do have to literally drill through the crown yourself to create that access hole. You can do that. If you prefer a lab to do that, you can do that as well. And then this is some of the stuff where we start talking about full arches, is that with this same scan body, you can then create these all-on Ts for multi-unit abutments that are completely customizable. So if you have an implant that's way off and you need to bring it back into the arch, they can customize these all-on T type of multi-unit restorations for you. And then if you're going to be doing some locators, you can have completely customizable what are called T-locks as well. So the locators can go off of that. They really, from a restorative dentistry, everything is completely customizable. And I'm sure they would be willing to show you where all the milling is done, which is right across the street at some point if we have a break. Any questions on kind of restorative stuff so far? Cool. When I pulled out let me see if this is still charging. We are charging. And then we just kind of talked about looping back. That was the first thing that I learned about. Then the next thing is when you start restoring implants or placing implants, we're going to talk about real quick about what's called the CEREC Guide 2 kit. In particular cases, when you're planning implants in the CEREC system, they have this lovely number called a D2 value. I've heard probably 15 to 20 hours of lecture on what the D2 value is. I'm still utterly confused over what it is. Essentially, real quick, don't ask me too many details. It affects on essentially what the drill is you're going to use and affects where you can essentially put your sleeve with your surgical guide. There's going to be a lot of cases where this surgical guide can't fit here because that's where the metal sleeves and it's going to run into the adjacent teeth. So in some particular cases, you're stuck essentially with the CEREC guide system when cases are like this and it's too small, you can't adjust the height. What True Abutment came up with was their CEREC Guide 2 kit, and they had different D2 values that you could put in the system that would then change the position of this particular sleeve, so then you could restore it. So if you want to learn more about that, I know they have classes that teach you about that. They have the guide over there, but all these D2 values allow to be completely keyless, so you don't have extra keys through the CEREC guide that you can make in your office that allows you to do single tooth implants. So I highly encourage you to ask them some questions after, but that was a game changer as well. And kind of this just goes through the protocols of all the different D2 values kind of in here based on where you kind of design that implant. So let's talk about why we add a cone beam to my office. I talked a little bit, it's just an amazing diagnostic tool. I've now started to use, when we talk about orthodontics and what cases that I shouldn't take on with clear aligner therapy, It's really, really easy for me to look at, like, I was taking some more follow-up. We want the maxillary arch, just talking about orthodontics, to be 5 millimeters greater than the mandibular arch if we're looking at proper, essentially, inclination of the teeth, and so they're not in crossbite. How do you figure that out without a cone beam? You can't. You're kind of eyeballing it, and you can also, from an orthodontic perspective, you can start to see, are the teeth really in the right plane, or do we, to kind of mask a crossbite or a class 3, are the upper teeth really lingually inclined and the lower teeth really, really flared out? These are things that I can start seeing by using the cone beam technology just for ortho. And I can often tell before going in there if this is a case that we can kind of take on, or if it's something for kind of screening new patients, or something that we need to refer for more comprehensive surgery type protocols. We're not masking some skeletal deficiencies. But why is to make sure we don't do any permanent damage. And that's really avoiding vital structures with the infraalveolar nerve. And I don't know how many times I see this. I see it very routinely where on a PA it looks like they have oodles of bone, 10, 12, 15, 16 millimeters of bone. But when we take a CT, there's this huge lingual fossa, and really we can only get like a 6 millimeter or 7 or 8 millimeter implant in there. We can't just drop it through and it would look fantastic on a PA. The only problem is we might causing them to bleed out because we drilled a little bit too deep. And I think there's a case where I'm designing a case here where that is a critical aspect of it. Buccal plates, making sure, especially in the anterior, that we're 2 millimeters away from a buccal plate. And then if we're going to be doing sinus bumps, making sure we have adequate amount of bone to do internal sinus lifts, and making the referral if we deem it necessary to do some lateral sinus bumps. So it's really looking in all 3 dimensions, making sure that we can kind of do this case. So let's talk about some implant fundamentals real quick and where we need to ideally place an implant. First, as far as height goes, we need to be 3 to 4 millimeters, the top of the implant, to where we want this implant to emerge from the gum tissue. It's 3 to 4 millimeters. I'm going to show you in a second why. There's some research done on that. Essentially, it's the biological width for implants needs to be a little bit longer than around teeth. We need to be going a little bit deeper than we thought. And I think this is where surgeons, when they've done hundreds and hundreds and thousands, if they're not planning it, they truly don't know. If you're not doing a crown down approach, you have no idea where that gingival margin of that crown is. So how are you ever going to know how deep to place your implant? They may think there's adequate enough of bone and they're putting it 1 millimeter subcrestal, but in some cases we need to go deeper than that to get the true emergence profile for that implant. And these are kind of the protocols that URIS goes by on almost every single one of these protocols. They have snapshots ensuring that all of these measurements are in the right spot. We want to have 3 to 4 millimeters between adjacent implants if we're going to be doing 2 implants together. We want to have that implant 2 millimeters from implant to the buccal plate. And then we want about 1.5 millimeters to 2 millimeters from an adjacent tooth. And then the protocols now is going 1 millimeter subcrestal. So when we're doing the hands-on portion of today's courses, all of these are designed 1 millimeter. So if all of a sudden you think it's too deep or it's not at the crest of the bone line, it's designed that way. So don't be surprised if we're 1 millimeter subcrestal when we place these implants today. So kind of what does that all mean with pictures? People call it kind of the 3-2 rule, is if you're 3 millimeters or 2 millimeters away from all these structures, you're probably going to be safe in all these scenarios. So 2 millimeters from the buccal plate, 3 millimeters between implants, and then 2 millimeters from adjacent teeth. And then again, at least 3 millimeters in depth from the platform all the way up to where the gum tissue starts. And I think this is really critical when you start thinking about if you're taking out primary teeth. primary laterals, primary teeth in the back, is usually that gum tissue is a lot higher than the adjacent teeth. And this is a mistake that I made on one of my first mediates when I took out a primary teeth and then placed the implant. I designed, and when I was designing the guide, is I did it 3 millimeters for where that gingival margin was of that primary tooth. That primary, if you looked at the adjacent teeth, the gums were, of the adult teeth, they were significantly more scalloped and the gingival margin was a much lower. So I really needed to look at the adjacent teeth and design it, the placement of that implant 3 millimeters below that particular implant. Or sorry, between the adjacent, the gum tissue, really 3 millimeters above that instead of where the gum tissue was for the primary teeth. And this is where I talked about, if you see any implant research on like gum tissue and gum health, this is the guy that's going to be doing it. I'm going to show you another one of his lectures here, is why we want 3 millimeter pocketing around, essentially with biological width around teeth, and why we need a little bit more, getting on closer to maybe 4 millimeters below that gingival margin for implants. So we talked a little bit about kind of that crown down approach, is that if we're planning this prosthetically, I want to make sure, I would prefer to do it screw retained if I can, and if not, at least I know that and I can then charge the patients and don't get stuck eating the cost of, if I'm not going to be able to get this screw retained with the proper path of draw and the screw access hole isn't going to be coming up the incisal edge of the buccal, I know that before we even get the patient to say yes. And this is where the surgeons that I've worked with, they've placed hundreds, thousands, tens of thousands of implants. If you're not planning on where that crown is going to be, you have no idea how deep to place that implant. And I saw a recall patient yesterday where the surgeon placed a great looking implant, it's well integrated, but it wasn't deep enough, and if it's not deep enough, restoratively, I have this tiny little custom abutment with this really, really thin zirconia crown that I'm crossing my fingers and hoping it lasts, just because there wasn't enough restorative space for me to restore it. And the patient's looking at me and upset with me, but really I'm handcuffed because the surgeon didn't place it deep enough. Or we run into cases like this, where this was done by my specialist in my office. He's embarrassed that I show this to him, but this is, and I know the patient he worked on. It's a very, very difficult patient. Not a lot of opening, tongue everywhere. He's always moving around. But if you had a guide, we can do this very, very predictably because we put the guide in and we know exactly where that's going. This is just, it's going to be a fun case. Like, we plan prefab abutments. We're not doing prefab abutments now. Like, luckily, it looks, he barely missed tooth number 28 or 29. We're going to now have to do custom, and we're going to have to get cement retained restorations in there. But luckily, I have true abutment in my back pocket. So I can still take my same scan posts, send it to them. They'll send me my core files back, and I can get as good of an emergence profile and as good of a long axis as possible to get this restored. But mistakes happen, and it's how we deal with them and having some things restoratively to fix that. But even the best surgeon in the world can have a bad day, and we have to kind of help rectify that situation. Or we can plan it on the CT with our data, with our guides, with our prosthetically driven approach, and we can get these implants so they're perfectly parallel, so we can restore this with ease. And when we talk about planning, the software will plan those implants perfectly parallel to each other. We don't have to eyeball it. The software does it for us. So what is an ISQ? It's something that I do on all the implants that I restore. And it stands for an implant stability quotient. What you do is you put a little magnetic frequency or a peg onto the implant at the time of placement. And you take this magical little wand and it sends a magnetic frequency down the implant. I don't really like kind of the subjective feel of implants where, oh, that went in well, that was a high torque value, that one didn't go in well, that was a little bit softer. I like to get an objective measurement, and this is what the ISQ does. It gives us essentially a number. 50 or 60 is not a great initial stability. 65 and above means you can usually put on a healing abutment, no question. And then if you're getting some like 75s and 80s, you could technically load that implant right then and there. There's the main, and there's a whole bunch of research backing this model of checking your implants. It was created first by Crestal, which they have their own version of this. Aseptico, which is the company that kind of all these motors are from, have come out with another device giving the same ISQ values called the Penguin. That's the one that I use in my office. And we're taking them at the time of placement, and then we're checking up every time the patient comes in after that to make sure that ISQ number is staying either the same or going up. Preferably I want it to go up because it means the bone is growing. And there's cases where when they come back in and all of a sudden I placed it at a 60 or 70 and they're coming back at a 50, I know that's failed. But I don't have to load it or torque test it. I know it at that point and we can rectify the situation and get it bone grafted. It does happen, but at least I know about that and we can address it rather than getting the restoration already in, making the situation worse financially for everyone because you're putting your money into it and then having to do some remakes. You can catch it before you get to that point. And then just in general, how the healing of implants occurs is you get that great mechanical stability of the implant at day 1. And then after that, all the way to the 4th week, you actually get some temporary loosening as all of the bone is starting to heal and remodel. And then you get the secondary stability at 6 to 8 weeks, where you get that true osseointegration. So I don't measure any of my implants until at least the 8-week mark. Even if they have ISQs off the chart of like in the 70s or 80s, I will probably go ahead and do some quicker loading and putting on my restoration probably at 2 months at that 8-week time period. Check it right before I put my restoration in, and then kind of move forward with it. So and the ISQ is truly the most accurate way to determine long-term success of implants. All this initial torque or how well it took a bite when it goes in, there's no correlation between long-term implant success with that. And that's just kind of going through the trends of what we're looking for. Crestal has a nice feature that will you program into the little the wand, and it'll constantly track that particular implant for you up on a cloud-based server. I don't like the Crestal because the pegs are one-time use only when you're putting it on the implant, and it can get pretty expensive ordering these new pegs. Or the Penguin from Aseptico, you can sterilizable and you can reuse them multiple times. And you can kind of see that number is like right around 70 is where you can start thinking about loading stuff. So I know we talked about earlier flapping versus a tissue punch. I think when you get in your newbie implant, the flapless or the punch is really, really intriguing because it's pretty easy. And I know we're going to be doing flapless today when we do the sinuses, just because we don't have scalpels and we don't have, and this tissue is really hard to get a nice, good flap release. So we're just doing punches today for ease of use. But we really need 2 millimeters of keratinized tissue around that implant to make sure the tissue and the gums are going to integrate. So a lot of times the flap allows us, if we're deficient on one side or the other, the ability to kind of do essentially a connective tissue graft and move that tissue over if we're going to be devoid of that keratinized tissue. But the other question I often ask is if we have to make a judgment call between the lingual and the buccal, where would you rather have more keratinized tissue? I'm going to disagree with you. The lingual, because we can always do some connective tissue grafting later on the buccal, where on the lingual we really can't. So if you have to make that decision where there's not a lot on either side, I would prefer you to kind of create a more buccal flap, position that lingually, and then we can then do some connective tissue grafting, which is not a very difficult procedure to do. But it's just something to think about. Now, most of these cases, I really usually have plenty on the lingual, so I don't have to worry about it. But that's just something to think about when we're talking about flap design real quick. So why flap? We can preserve, create more keratinized tissue, and the second key is, I think, the most important here for me, is I'm using tie bases. And if I want to know what type of tie base, and I don't want to have any impinging on the bone and making sure that fits, I want to see where my bone is, and I want to see how much I have to profile around that implant.
So just a quick question. There's a lot of conversation these days on a guided implant surgery where people prefer touch versus people who do flaps.
Yeah.
Even on a guided surgery. What's your preference?
I still am flapping everything.
Even on a guided surgery?
Even on guided.
The tissue.
Because of both of these two reasons. Preserving more keratinized tissue in cases, but even if I have plenty of keratinized tissue on both sides, I want to visualize that bone. And that's my preference. You may disagree with me, and you're definitely entitled to that opinion. I've had enough cases where stuff I can't get to especially as a CEREC doctor, where I have issues with just the integration and of the bone running in the way, if it's not perfectly profiled and flat. And I don't like redoing cases for something that could take me as little as like 5 or 10 minutes to get something to flap that's open, to flap it open rather than punching. So why tissue punch? It's easily and it's minimally invasive, and I think a lot of new doctors getting into implants, that's intriguing to them. But I think you're going to have some essentially, what's the phrase? Short-term pain, long-term, no, short-term gain, long-term pain. I think that's what you're going to run into when you're not flapping. And then here's a particular case where I think you think you have oodles of bone, but really like this chunk of bone is actually still grafted material, and when I did flap it, that all like flapped into my flap, and there's a whole bunch of bone on there. So really that, I needed to place it even deeper than that, and I wouldn't have known that if I hadn't flapped it to see where the true bone level was. It was still like this not fully osseo-integrated bone on this particular case. And you can kind of see there's a little bit of a flap here that has popped up that kind of gives you this like distortion of where the bone truly is. And the other thing I like to talk about is I am always taking my final impression for my implant crowns at the day of the surgery. I selfishly started doing it in the beginning because it was very, very efficient. And I could then do only essentially start to finish A to Z implant in 2 visits. Placement, take scan, and then deliver my restoration in about 2 or 3 months. I thought it was a very snazzy little workflow. And I think doing that digitally is the only way you can do that. You can't essentially have everything open and flapped open, put on your scan body, and then take impressions or your impression coping, or whether they're open tray or closed tray, with all of that blood. You're going to get some inaccuracies and distortions. But digitally, all I need is that top 1/10 of a millimeter of that scan body, and I know exactly where that implant is. And I'm also pre-scanning, so every case that I do an implant, while the patient's getting numb, is I'm taking the full arch scans. I'm taking, and then I have my separate scan body folder, or my impression, essentially, of that implant impression coping or scan body after the implant's placed while it's still flapped open. But now there's some research that's showing that actually this is probably the preferred way for the long-term health of that implant. And what they're realizing is every time we take something in and out, whether it being a healing abutment, cover screw, impression coping, crown, temporary crown, you're constantly reintroducing bacteria, and the body and the gum tissue is constantly having to remodel that biological width. And it essentially, every time you do that, it disrupts that peri-implant biological width. And I talked about that guy earlier that did implant, that's that same author here. Who's come up with this kind of concept called an abutment swap, and you want to limit the amount of swaps as possible. So if I can do that scan at the time of surgery, all I have is one swap. It's taking the healing abutment out and the crown goes in. And it's also why a lot of these implant companies are coming up with this healing abutment that stays on permanently, and then you're putting the restoration on top of that. Or why the 3i came up with like their N-code abutment, where all you have to do is scan the top of the abutment, is so you don't have to be taking stuff on and off multiple times for impressions. That's why they're doing things like this. So the other thing, and this is why I truly like the URIS system, is when it's fully guided and fully timed, we can have custom healing abutments made. So I can idealize, essentially from the gums down, exactly how the gums should be. And I don't have to be putting any extra undue pressure and really not disrupting that peri-implant biological width by having custom healers made for every case. And I'll show you some surgeries that we did that we videotaped and if you looked at some of the cases I've shown so far with URIS implants, you have the custom healing abutment on there. Let's talk about in-office guides versus lab fabricated guides. So in my office right now, if you have the traditional CEREC software, you're essentially stuck to one implant per guide. So if you have multiple implants that you're going to be placing, you're going to have multiple guides. So in my office, if I'm doing a single implant, I'm making that in-house. And as soon as I get something more complex, I'm sending it to True Abutment and URIS for them to take care of. Because I don't know about your office, but for whatever reason, my office team likes to put like 6 surgical guides all on the same day. And then I'm sitting there like after hours for like 5 or 6 hours, like maybe not 5 or 6 hours, but a couple hours, like planning these cases when I have my wife, the real boss, calling me and like, where are you? What's taking you so long? I can then essentially farm these out to them, let them take care of 99% of the planning, and if there's some question, they'll call me. Or in cases like today, I have to go see someone over there because I have a question about a guide that I sent them this week. So if I disappear at lunch, that's probably what I'm doing. But in-office surgical guides can be done the same day. They're cost-effective. They're single implants, and then they're milled or printed. So if you have a 3D printer, you can be printing them. I have both, but I still prefer my milled guys. I feel like they just fit better. And I never have really had any fit issues with them, so I've never really jumped into the 3D printed, the world of essentially printing my guides. I know people that have done it successfully. For me, if it's not broken, don't fix it, and that's why I continue to mill them. If you do mill them, real quick, for those guys that had CEREC, I highly recommend, and it solved 99% of my problems, is it's a weird trick, but get aquarium reef filters and put that on the bottom of the CEREC machine. and that essentially allows the water to soak through, and all of the shards from the milling of the guide, it catches all of that so it doesn't clog your machine or your filters. It's really affordable if you go to PetSmart or Amazon or something like that. And then cases where I will do lab fabricated is multiple implants if I need something that's fully timed. So for any aesthetic cases in the front where we're trying to get proper emergence of the implant, it's less work for me, and then I know when they make their guides here, they're all printed. It's like some fancy, really accurate carbon printer, yes? Something like that? Yeah. So you're going to see me designing two implant restorations and how long it takes me to do that. And if we're talking about me have to do 4 or 5 of these, I'm there after hours for more time than I want to be. You can see I already made a quick mistake there. I actually had it labeled 30 and I was designing it for 29. So I do make mistakes. And it's kind of learning from those. So I'm creating an ideal, essentially, profile, a crown down approach to implant planning. So I'm essentially creating the margin of where I want that tooth to be. And then I'm planning this case as well, where I want, ideally, tooth number 30. And to me, it's really important to get an ideal buccal margin for that. Because if I know where that ideal buccal margin is, I know where I need to get at least 3 to 4 millimeters depth of where I want my implant to be. So I'm just going to make some fine-tune adjustments here on the design of my crowns. I really didn't need to do this, but I'm being OCD. Yeah, let me finish this and then we'll take a break. So what I'm doing is I'm exporting this, in this particular case, as an SSI file. If you're sending something to URIS and True Abutment, you don't even need to do this. You don't need to do any of this. They're doing this all for you. And if I highly encourage, for those of you that are just getting into implants, do both of these first, plan your own, because it's a great learning opportunity, but also send it to the guys here because they're doing hundreds, if not thousands of these a week, and they know what to look for, and really compare the two of them. So at a certain point, you feel confident to do this on your own. So I'm marking the nerve here. Now we're bringing in that file that I just created in the CEREC software, that crown down approach, and I have to bring it in twice, one for each tooth. And this is why you have to make guides twice if you're going to be doing it that way. I'm marking essentially all the like points to making sure this file merges properly. And now I'm just checking to make sure this stitch has stitched properly together. That there all of a sudden isn't some distortion, and then my guides aren't going to fit properly. I'm bringing in tooth number 30 now, and we're going to do the same thing, where I'm going to go ahead and stitch everything together. And we definitely want to talk about metal artifacts. So you can see I'm picking essentially teeth that are not crowned, especially if they, to make sure we get a good stitch. That's the best way possible. And there's some tips and tricks if you're having like a full arch of metal PFMs restorations. URIS has these little stickers that you can get. The other thing I've gotten is just flowable, radio opaque flowable, that I put on multiple teeth on multiple positions and scan them both with my scanner and then also the CT scan. So you all of a sudden see this big bulge coming out of a metal crown. You know that's the marker that then stitches with the CT scan. So then we're kind of placing implants digitally, and I'm looking to long axis of this tooth to make sure it's coming out for a screw retained restoration. And then I will probably be doing, I think I already did it where it says 3.94. I'm already making sure that I'm at least 3.5 to 4 millimeters below where that margin is supposed to come out. So I'm going to kind of redraw it again. And I'm a little bit more than right around 3.94. I think the body will be happy with me if I'm 0.06 millimeters off. But this is a perfect example of that case where you look on the PA and you think you have so much room, but where you have that lingual fossa coming in, and I'm kind of threading a needle there with how close I am to that kind of the lingual side. You would never have known if you didn't take a CT. The other thing, I don't know if you just noticed, if you are going to be planning your own URIS implants, like this one, like that's a pretty big lingual frame in there, or lingual fossa. The body of a URIS implant is the same shape and size with a hyoscine implant. So if you're going to be doing it on your own, you select the hyoscine type of implant in these implant planning softwares. I'm sure as these implant planning softwares get updated, they will have URIS in there, but for now, this is the workaround. And then I'm kind of measuring in between, making sure I have that 3 to 4 millimeters between my implants. And then I'm 2.2 millimeters away from that buccal plate.
So your guide is part of your overall implant. I mean, how
Fee?
would you charge for this? Is it part of the fee?
Yeah, I mean, we can break it down if it's like an implant, like if we're talking about like a PPO fee, then we break it down and it's usually around $300 or $400 for a surgical guide.
I'm sorry, 300 or 400?
400, yeah. And I charge that to the patient. And then this is where we're talking about sleeves and where we can kind of put sleeves and orientate them. And this is that dreaded D2 value that I was talking to you about. And the reason I'm picking 18 and 22 is because that's what the True Abutment Sarah Guide 2 kit, those are the numbers associated with that. And I'm looking at seeing where is my guide sleeve in relation to all those D2 values and what's the best for me to place that implant with that guide. And then we have that guide ready, we export it, and then we send it out to either my milling unit. In this particular case, this was just a demo of a case like that I was practicing on. And we sent this to URIS to be made. And I think that's the case placed. So 2 parallel implants. This one's a little bit shorter because we had that lingual fossa a little bit farther back. And then we have the custom healers as well. So I think now is a good time to take a break. So let's take a 10 or 15 minute break, and then we're going to focus in on just URIS implants and kind of how we place them fully guided. And then we'll focus in real quick on sinus bumps. Cool? So I'm going to kind of review why fully guided, fully timed, especially in the anterior, make a lot of sense. I do it everywhere, but if you're only going to doing it in one place, I would highly recommend doing it in the anterior. And that's to get the surgery, it can be quicker, but all these pieces, if we're doing immediate load cases, can be done, all done beforehand, so we don't have to be having the patient stay in the chair to make all of these temporaries once the implant's placed. So I'm also going to go to just what traditional aesthetics before digital used to entail. And you're going to see there is an awful lot of steps. There's impressions, there's stone models. You can freehand it in the mouth. You can have it be made by a lab. You go back to taking an impression. You do a stone model with a temporary crown. You take a custom impression coping. You do another stone model, and you finally get to your restoration. That's when you scan at the time of surgery. You either make your temporary crown, you scan again, and then you make your restoration, or you can do some 3D printed models. Not as many steps, so it's a little bit more streamlined. You can now literally get this down into like one step by everything pre-done and pre-planned. But this is kind of what we did for this particular case. We did this case about 5 years ago. Where we scanned before the extraction was done, and we made a Maryland bridge. I think all of our patients, if the occlusion allows for it, would prefer a Maryland bridge during the healing time rather than having a flipper. So just be aware of that as an option, especially if we're doing something in-house. The cost for me to make a Maryland bridge is $30 compared to sending that out to a lab. But essentially, scan at the time of the implant placement, and then we made a custom healer at implant placement, and then we scanned and we did a restoration. This is my typical, before fully timed guides, was my typical workflow. We eliminated, in this particular case, the second scan. So everything I did was essentially, we did this appointment in 3 visits. Visit number 1 was this step right here where the tooth had come out. And it was a tooth number 8, fractured at the gum line with a nice big post. Essentially the gum, half the post and half the tooth was with the crown, the other half was in the mouth. Second visit was where we did the majority of the work, where we immediate extraction, implant, did all of this work here with the custom healer and the temporary, and then that temporary looked pretty damn good in my eyes, so we used that temporary to be making the final restoration. So this was at the emergency appointment. I then, once I had this scan in my hands, I made the Maryland bridge, and then we cemented the remaining part of the post and core back in and got him about 2 or 3 days so we can make the surgical guide. We take the impression, the scan body at the time of placement. We couldn't immediately load it, but we can put a healing abutment on there. And what I did is then, as the patient was sitting there, went ahead and made this temporary crown. To me, I do this for 2 reasons. One is because it's a bigger tooth in the milling unit. When we're talking about implants, it mills faster. Couple minutes here or there, but any time is money. The other reason I do this is I want to see how close I can get aesthetically to giving this patient a good result. And if I'm happy with this, then I have essentially the crown that I can make ready to be delivered. I then have marked this particular with some graphite pencil, and that's where I want to cut off essentially what's crown down, or essentially the crown of the tooth off, and then have so it looks like this, just with my high speed, to just kind of chop it off. And now from the gingiva up, everything can be healing, and it can be healing in the ideal fashion with the proper emergence profile. And then we're going to go ahead and, there we go. cement the Maryland bridge over the top. Maybe not the most greatest junction between here, but I think this patient prefers having the Maryland bridge to the temporary. We then fabricate a custom abutment, and this is 4 months later. And we go ahead and deliver that implant crown before and after. Still, this is the day of delivery, so still the papilla hasn't really folded in. That's kind of still at the day of delivery, but I think a pretty good aesthetic result. And then this was, I actually saw this patient about a week or two ago, and you can see the papilla has kind of filled in nicely. So if you kind of respect the biology and get things as ideal as possible, I think you can have great aesthetic results while also being really, really efficient. I thought that was efficient at the time. Now I think we can even expedite this a little bit even quicker because we can have all of that other stuff that I was doing chairside pre-made for us. And this is kind of just going where we essentially removed a whole bunch of steps. But all those steps that technology allows us to do, it just is eliminating all of these different things that we have to do. So, quicker surgery. This is a patient that I'm actually in the middle of this case right now. And I feel bad for her, but she literally keeps falling and breaking stuff. The first time she ever came to my office, she had fallen, and you can see broken tooth. This one was broken at the gum line, and she was like, I'm not doing implants. And I was like, okay, we can do a bridge for you in this particular case. So this was fall number 1 with this particular patient. So we take that particular tooth out and we do some zirconia bridges that we milled in-house. So I think we got this patient a pretty good aesthetic results given to where she was at. Then about 9 months ago, we get a call that she's fallen again. I don't have pictures of that particular fall, but essentially she had broken all of these teeth all over again. So that bridge that we did a handful of years ago is now on the table, and she has some remaining root tips. So we have to do some extractions. We did a little bit of bone augmentation, some guided bone regeneration, and we get these URIS implants in place. And this is where the custom healers really come to our advantage. And on all of our custom healers, there's a notch on the buckle, and that notch on the buckle is essentially where you want to orientate it. And when we start going through these kits, all of the drivers when we're placing the implants have notches that line up exactly where the hex is. So these pieces fit right in place, and that's where the fully timed comes from. So we now have 3. In this particular case, I did make her a flipper, but you can see these little tiny notches that are here, and essentially everything from above the gum can be healing and integrating. And this is a case, I literally saw her earlier this week. Yes, it's not ideal like I wanted to, and this is probably about 5 or 10 minutes after I took these off and started scanning. But my protocol is as soon as these abutments come off, I have the scanner right there, and we can scan the proper emergence profile to give the lab technician the best case possible. And while CEREC is phenomenal, just because I have a CEREC doesn't mean I'm making everything with the CEREC machine. I'm not a lab technician, so yes, as a CEREC doctor, I do still send stuff to the lab, and that's okay. I don't want to be there longer than I have to. So this particular case, I will be seating, these are the scan bodies that we have taken. All of them were taken with ISQs. The ISQs have gone up since we placed this. And she had a lot denser bone than I was expecting going in there. I thought these were going to be some that I may have essentially done a second stage surgery to open her up and access these. But she had a nice high quality bone in there. We now have the scan bodies taken. We take that scan body, that digital image, and send it off to the lab. So that's kind of the workflow now, where we can have all of this stuff pre-done for us and really save a bunch on the chair side. If I wanted to, instead of having those prefab custom healers made, True Abutment and URIS will actually make temporaries for you as well. You just have to give them the shade and kind of in the ballpark. In this particular case, I wasn't expecting her to have the bone quality that she did, given that we had to do some ridge augmentation when we took the teeth out. So these are some of the qualities that I'm looking for in like an ideal scenario or an ideal implant. One is we want to have the platform switch. 2 is we want to have a conical connection. 3, we would love to have good initial stability. Makes us feel a little bit better when we put the implant in there. 1, my preference is a high ISQ value. And then we have to have size and length options. We have to have some shorties down in like the 6.5 to 7 millimeter options. We also have to have some the widths. I personally don't place anything greater than a 5 as far as diameter goes. I don't think you really need something greater than that. And my thought process is that if we're getting 5.5, 6, 7, how much bone, like I would rather have more bone surrounding that implant than less bone if we're talking about kind of sizes of ridges. Really, I don't think you need, from a restorative standpoint, even if it's a big space, I don't think you need anything bigger than a 5. And then for me, because of my why, I want digital workflows. And that's kind of why I started using URIS. Is that it checked all my things that I look at for implants on what I need. So let's talk about each one of those in a little bit more detail. The platform switching, so the implant and the abutment don't just come straight up. There is a little bit of an indentation, and all the research shows that the reduction with the platform switching causes a little bit less peri-implant bone loss. You can sometimes even get bone to grow over that little platform switch as well. And then the Morse taper or the conical connection right now I think is the best connection that's out there on the market. Just reduces the micro movements, and if you're trying to eliminate that micro gap, less bacteria are going to get in there. So how does the URIS system work? Is they need 2 things from you, and it doesn't matter where you get those 2 things. You need an STL file or a digital impression, and you need a cone beam. And you send that into them via their portal, which is urislogin.com. When you set up an account with them, they'll give you access, and you submit those 2 particular pieces of information, and then they take care of the rest. If they have any questions or concerns, if one of those measurements that we talked about where we ideally want to place implants, if you're going to be violating that, they will be giving you a call and asking you how you want to handle that situation. They will then ask you if you wanted a 3D printed model, if you want custom healers, if you want temporaries, if you want what shade temporary. There are a series of questions that they will ask you, and then they will be sending you the fully guided surgical guide with any of the pieces, and it's a 2-week turnaround at this point. Any questions on that right now? No? Interrupt me, please. It means that you guys are at least listening. So, in this particular case, we're doing, he had some retained primary molars, so we're going to be putting implants in 4 and 13. So this is kind of this is what one of the surgical reports looks like. It's what the surgical report looks like. You have an abbreviated version of it on your desk when we get to that, but I'm going to walk you through it real quick. So, guide with all the different slices. And then this, in my particular case, if I'm doing something, whether it's twosies, I want to get those implants as identical as I can. I would rather have, if I'm doing 4.5s by 4.5 by 11.5, I want both of them to be 4.5 by 11s, even if I can get 12 or 13 in there, just because the surgery goes quicker. I can literally just go back and forth with the same drills, and it makes my workflow a little bit efficient. So this is the protocol that they will send you. If you want to be doing a tissue punch and you're not going to be flapping, you can do that. And then this particular sequence of drills lines up exactly with this sequence in here. And we'll go through this step by step. We'll have you come up here and kind of over my shoulder as we do start placing these implants. The most important thing on here is this, what's called the guide sleeve offset. There are 3 numbers that it can be. It can be 9.5, it can be 11, or it can be 12.5. And essentially this helps when all in those cases where I was talking about the D2 value and I can't get my guide into the place where I want it to be because the sleeve runs into the adjacent teeth. This moves my sleeve up and down so they can make a guide for every single case that's out there. I have yet to see something where they say there's some workaround or we can't do this or you need to freehand it. This is key because this little, when we actually place the implant, this side over here, there's markings that correlate with the 9.5, the 11, and the 12.5. And you're going to see a case where I videoed the live surgery where I forgot about this and I set the implant to 9.5 and I looked at it and it wasn't subcrestal and I'm like, what's going on? What's off? And I looked and I had forgot that that offset was 11, so it would be 1.5 millimeters deeper because I didn't put it down as deep enough. And I always star this and I highlight this on every single one of my cases that I get from them. The other thing that this has when we start getting it, is you start looking at these cases and start opening up, there's like lines and essentially hexes, and this engages the implant perfectly on the hex. And these indentations are what you line up when if you actually look at your guides, there's little metal like lines on your guides. This has to match up with those lines to be fully guided. And those are the 2 small little things that you can't overlook. The other thing with this kit is all of these.
I'm sorry, going back.
Mm-hmm.
Did you say that you couldn't use the kit if it didn't fully line up with these lines on the guide?
So all of these, when we're talking about implant placement, all of these on both set, when we start talking about implants, see how there's essentially markings here? Those markings you want to line up with this, and therefore you know it's hexed. The orientation and the timing is correct.
So that dark line's in my
Yeah, yeah.
So then you can make your own. You can really then make your own guide using the system.
What system? CEREC?
Yeah, if you do CEREC guide, how are you line
You
this up?
can't. That's when you lose the fully timed feature. Okay. You can still do it guided with the CEREC 2 system, but if you want something fully timed, you have to have them make it.
Or switch to time marking.
Okay, yeah. Do you guys have that in there? Yeah. Okay. So, it's one of the downfalls. CEREC's not perfect. There's a lot of, like, the D2 values, we can't really change, but that's something, that and then the full timing of it. I'm sure they're working on it, but these are the things, like I said, why I like true abutment is because I've asked CEREC to come up, or Sirona, to come up with different tie bases for like 10 years, haven't done it. We've asked about D2 values, haven't done it. You can now get your CEREC system if you want to pay what's called a Zento, and they can do it fully guided, fully timed for you, but that's like $2,000 an implant if you want that. So, but we'll walk through, and you can kind of see here as well, for those of you that I was just showing him in person, but these little notches, this black line will line up with the little metal, little outcropping on your guides. We're all good with that so far? Okay. And essentially I just said the same thing. But that little indentation is going to line up with that little mark right there. And then we have 2 sizes of implants. We have the narrow, which is the 3 and the 3.5, are what's called the yellow. And then anything above a 4, a 4.0, 4.5, 5, and I think they have a 5.5 and a 6, if I'm not mistaken, will then go with this kind of black driver, and then that color is green. And I like that because I don't have to have multiple sizes and multiple scan bodies and multiple scan posts just depending on the size of the implant. Keeps my, my stock pretty simple. So this is a guide we'll go through real quick, but usually it kind of starts in here, and then you slowly kind of work your way up to the depth of the implant and then work your way over. The other thing which I know on my kit in my office, and I'm not seeing it here, is that if you want to, you can get the guided kit, but if you still want to do it free-handed, you can do it free-handed because there's markings on these, on the osteotomy drills to tell you what it is, what the size of it is. So if you just want to do it free-handed, you can also do it free-handed. Is that something you guys changed, or am I just looking at a different kit?
No, you're looking at an older kit.
Okay. There you go. So it can be, this Pylon kit can be done guided, also non-guided. So there's the particular case. Yeah, I probably didn't have to flap on this particular case, but I did. And you can still get the flap out of the way. You have the notches, and then I'm going back and forth real quick, back and forth with the same drill to be really efficient and getting the osteomyotomies in place. This is me taking the final impression for these crowns at the day of placement. Going back to that kind of abutment swapping that we talked about. These are my custom healers with the notch on top, and then I'm just putting a little bit of Cavit IRM in the access hole with some Teflon underneath. This is me then, as soon as the surgery is done, I'm going ahead and designing my crowns. I'm now going to get my, that's what they look like at placement. And then with the GH2 tie bases from True Abutment, I can get over that crest of bone and get that predictably restored very, very efficiently. And this is a particular case where then if I have to start thinking outside the box and I don't want to spend a little bit more extra time and I need to get home, is this a single, but I did send this off for them to make the guide. And this is where, in this surgery that I'm videotaping, you're going to see that I forgot what my offset was. And I go back in a couple minutes later and essentially torque it down or place it about 1.5 millimeters deeper because I was thinking it was a 9.5, and it was actually an 11 millimeter offset. And it's because tight spaces, small spaces, that D2 value that they're normally used to using has to be extended a little bit so we can place that fully guided. And you can see right here where the offset now says 11 on what we, why we need to do it. And then in this particular case, since we're doing an immediate, they have these socket drills. In this particular case, I really didn't need them. But if, I know some doctors, if we're doing immediate molars and we're sectioning the tooth, a lot of doctors like to go in with some what are called drills in the first place, and essentially between, like if you're essentially splitting the tooth and sectioning it, they will use these socket drills instead to split the tooth, do all their osteotomies, and then extract the tooth. And what these socket drills are doing is they're a little bit more hardy and sturdy, so you can actually cut tooth with them as well. And these are all in your kit as well. They're up in the upper right-hand corner. So that you'll see me use that real quick. And this is what the socket drill will do. It'll essentially remove any remaining tooth structure. And then once we get rid of the socket drills, then we'll go ahead and start doing our osteotomies. And something that's a little bit different, and it's not in the traditional line flow that you see here, is the first drill will always be a 3/0/7. And what they realize is if you go to a longer drill that's a little bit smaller, you can sometimes get a little bit of wobble. So they want a shorter, fatter one to begin with to get a nice start for your osteotomy. And you're going to see that on all the protocols that we're doing today. So that's what most people think is usually the first osteotomy drill, but in this protocol and all of the URIS protocols, they do it as a second one. And then we just kind of walk through like a cookbook recipe to get all of these osteotomies done. If you feel like skipping one, that's yours. But I usually go by what they recommend. They do hundreds, if not thousands, of these every week. And then towards the end, this is where you have to get a feel of the bone. Is it soft, normal, or dense bone? And they give you the protocols for dealing with situations like this. If it's going to be, I think this is like a 4.0, are we going all the way up to a 3.8, or are we going to be stopping at a 3.4, depending on the feel of the bone, or a 3.9 in this particular case. And then we place the implant, again, making sure that these little notches are lined up with the implant at the end, or with the guide at the end. So this is kind of a live video, and all I did was, I think, time this up by 2, like sped it up by 2. So you were saying an hour or so for your implant procedures. I think you can get, you can start being really, really efficient and quick here. So I have a piezotomy in my office. Does everyone know what a piezotomy is? Yeah. So I use that a lot for my extractions. It's like a little mini jackhammer instead of drilling the bone away. It's conservative, creates a little area so I can get my elevator in there and start extracting. So this is the piezotomy. I go in there really quickly and kind of can get that tooth out very atraumatically and very, very efficiently. I always laugh at these videos because I wish my hands moved this quickly.
Is that just hook up your bracket tape, or do you have a separate?
It's a separate unit. Yeah.
Love it.
I do. What?
Use it every day.
I'd say about 50% of my extractions I do. When there's like root tips or stuff like that, it just, I don't have to get like the big bone profiling burrs out. You don't know how far down you go.
Yeah, I had a case where it really was, I thought they had stuff.
Stop.
And I went down a little bit. It didn't really impact the case too much.
Yeah, I mean, it'll tell you. There's lines on here, and it'll tell you how deep to go. But yeah, there is no stop. So tooth out, curetting the socket, making sure it's nice and clean.
To be exact, there is a stopper on 9.5 offset, but we don't recommend using the stopper because when you're torquing the driver in, it's very easy to go past the stopper. So if you're blindly just torquing it in.
We're talking about the socket drills.
Oh, sorry.
Yeah, it's okay. You're talking about implant on that other drill that's in there.
Yeah.
Not on this kit because I have the old kit. So guides in place. We're now doing, which I probably didn't need to do, but I'm doing those socket drills. And I think that was one of the first initial osteotomies that we're doing. And then with guided, just kind of reminds me, always try to keep that bone as cool as possible, so as much irrigation as possible, because a lot of irrigation isn't going to be able to get through that guide here.
So that guide is pretty sturdy.
Yeah.
Doesn't move at
No.
all.
You'll see some of the guides, when we do the sinus bump cases today, on how sturdy they are. So I think that was the last initial osteotomy. We're going to go ahead and just curette it, irrigate it again, and then get ready to do the implant placement. And this is where I made the mistake and went, so the initial one goes, you'll see when we get to it, but the initial one you just get it in there and then you start hand torquing it and getting it down to the depth that you want. And this is where I screwed up and got it down to 9.5 offset and needed to get a little bit deeper. You're gonna see me take it off here. So the torque here was okay at like 35, but then I stopped and I'm gonna take an ISQ value, and the ISQ was like in the 60s, which is not bad for a immediate placement. But that's where I'm like, that doesn't look right. It's not deep enough for what we had planned. And then I remembered, so this is the ISQ value, and I'm gonna do it essentially twice. And as we got it another millimeter half deeper, the ISQ went up, and then we can then put on a healing abutment. So yeah, it's a 65, which is kind of right at that number that I never like 65, because I have to make that judgment if I'm gonna do it or not. And I think I even scanned it and then realized after I scanned it that I had to go back and redo it.
Oh.
Or actually, this is the pre-op scan. I usually have taken pre-op scans before we even do the surgery. In this particular case, I think I didn't. Because I don't even think there's a scan body or a scan post in there at this point. Taking the lower arch.
If you had a good ISQ value at the end, when you retorqued it down to 11.
You could immediately load it if you wanted to.
Yeah, why not immediately load it?
You could. I don't know. That's your call. I'm a little bit more conservative. I don't like to do that. Is it worth waiting like 2 or 3 months? You could absolutely do it if you. I mean, if you're getting, to me, I don't know where your cutoff is, but like 75, 80
Right.
in that range, yeah. So this is where I go back with the guide and I put it down another 1.5 millimeters. I didn't, because I did all the drill sequences, because all the drill sequences were planned without an 11.5 millimeter offset. What wasn't, which is the only thing that you can screw up, which I did, is putting it that full depth. And that's really the only time you ever have to think about it, is the very, very end when you're placing the implant. So 73 went up 8 ISQ points, just by going a little bit deeper. Let me put the scan body on and then get her ready for the delivery. And for me, the notch is important because the notch is going to tell us where the sprue is going to go. And I would prefer to get that sprue away from the interproximal area. And with CEREC restorations, wherever the notch goes, wherever that cap goes, it's 90 degrees clockwise from there. So I always try to put that notch interproximally, knowing that the sprue is going to be 90 degrees away from there.
Are you ever using just a regular CEREC scan post or something like this?
No. I think
You
there's
use yours all the time?
I'm using true abutments. True abutments.
Right.
Yeah. I think there's also some research coming out that they want the restorative platform starting to be at least 2 to 3 millimeters above the height of that implant. And if we're talking about CEREC, we're stuck at 1. And then in this particular case, I used what was called ossix bone. I have mixed feelings with this product. I probably wouldn't use it again for an immediate placement because it doesn't show up on an x-ray and it doesn't show up and become like radiopaque like bone for like 4 to 5 to 6 months after you place it. So when you go back and look at these cases, you've put bone in there, but it doesn't look like you've actually put bone in there until 6+ months, and it just gives me a weird feeling. So when I do immediates now, I'm switching away from this and just doing PRP, PRF, and get some sticky bone with it. And then we're just kind of suturing it up. And we've already put that custom healer on there. So, and we'll kind of talk about PRF and PRP here. But that's kind of the final placement of that implant, just like we had planned with the screw retained restoration on top. Any questions about just URIS single implants or double implants? All right, we'll go do a little bit deeper dive. I'm going to go through this as quickly as possible because we're supposed to be wrapped up with this in 20 minutes. So internal sinus bumps, we want at least 5 millimeters of maxillary bone in the vertical dimension to pretty routinely have success with internal sinus bumps. If it's going to be less than that, you're going to see a case that was a little bit more aggressive, and I think we were down into like the 4 region, but it was like 6 or 8 on like the mesial half, and then there was like 4 on the distal half, and I felt a little bit more confident doing it. But if it's less than that, it's going to be a lateral sinus bump. And for me, that's out of my comfort zone at this point. But looking forward into the future, that's kind of something that I want to probably focus in on in the next year or so. So CT scan, why it's important is it'll kind of show everything in all 3 dimensions. If we're talking about sinuses, expect to perforate them. That's okay. You're not the worst surgeon in the world if you have a sinus perforation. It's going to happen in 25% of cases. We'll see how well all of you do today, because we're all going to be doing it and see if we perforate it. Hopefully I'm not the one that does it. Yeah. If you perforate it, you have to take an extra shot before you leave. And that sinus bumps with implant placement are still very, very successful, even if you perforate it. So let's talk about sinus perforations here real quick and the types. And essentially it's just based on the size of the perforation. If we're doing internal sinus bumps and we're placing 5 millimeter implants, we really shouldn't have a tear bigger than 5 millimeters. Something went drastically wrong if all of a sudden we're making osteotomies that are less than 5 millimeters and we have a hole that's 5 millimeters to have a sinus perforation that's bigger than 5 millimeters. So almost everything we're going to be talking about right now is going to be following into this class 1. These class 2 and class 3s really come when we're talking about lateral sinus bumps or lateral sinus lifts and how you deal with them. That's not what I'm going to be talking about today. So if it's 0 to 5, no collagen membrane is needed. PRF membrane is highly recommended. We place the bone graft in the implant, and we also know that the sinus membrane does have properties that will allow it to grow bone again. So we're relying on the biology to really help us out, and we can kind of supplement that biology by using PRF. So that was something that I was hesitant about a year ago, and we added that about 6 months ago to our practice. I'm going to kind of talk about PRF, PRP, and kind of where how we do it in our office. If we're talking about class 2s, so this is like if you're doing bigger than 5 or 5.5 or 6 millimeter WISE implants, you may get into that. That's where we need to go ahead and put some type of collagen membrane up there, place the bone graft, and then I would hold off and place and essentially do it in a 2-stage. Do your sinus bump first, allow that to heal and integrate, and then go back in a couple months later and place the implant. And then class 3 is for another lecture taught by someone else. So I'm not doing laterals, and that's really, that's when you're going to start coming across that, or if you get to that point, you're going to be sending them to an ENT or something like that. And I think I posted it next. This is the article that talks about all of the sinus issues and sinus membranes. I think it was like from the Implant Journal of Europe. I think is the very rudimentary name of the journal that all of this information came from. So let's talk about PRP, PRF right now. I think there's two main PRP and PRFs. I think most people have heard of what's called, if you're doing it, know of the intraspin system, which is, I think, coming through BioHorizons. And they have what's called like a tilted centrifuge. So it's like 45 degrees. What I've been trained on is a professor that is an Canadian professor that now lives in Florida but did all of his research in Switzerland. A dentist, but he did all of his research on PRP and PRF. And what he realized is putting it in the centrifuge and getting the blood draw, it's the centrifuge that has a critical impact, and this centrifuge goes completely at a horizontal, or 90 degrees to the rotation. So these are spinning completely horizontally, and it does a much better job of separating the red blood cells from the white blood cells. The key in all of his research was that when the phlebotomy is done, when we draw blood, we need to get it into the centrifuge as quick as possible. So preferably under 90 seconds. Between 0 and 90 was all relatively the same. And then after 90, the amount of the plug size and the amount of the good stuff that we're trying to get started to decrease after 90 seconds. The other good thing about the horizontal centrifuge is you can spin it at lower speeds, and that helps with getting all of the good stuff, the white blood cells, all the growth factors into that plug as best as we can. And then there's also what's called PRF and PRP. So with the intraspin system, you put it in the centrifuge for about a minute or two, and it does a good initial separation. You get this plasma, and you essentially suck it out with a syringe and then mix it up with your bone. And then there's his protocol, which you can do and get this plasma, or you can just spin everything and get it to all what's called fibrin. And that's what I call the boogers, or the clots that come out of there. And the comparison that he used was the fibrin takes the body more time to break down. So it's more like a drip irrigation system where the body has to break this down, but as it breaks it down, it gets all of these PGF, all these bacteria that help with growth. It's constantly being trickled into the body, and it lasts longer rather than the plasma, which is just liquid. It kind of just is as a downpour and kind of washes away. So he's really focusing on a lot more using the fibrin. You can cut the fibrin up into a bunch of little pieces like chop suey, and it's all these little pieces then you mix with the bone. You can use it as plugs, where you put it in this container and then put it as like a plug, or you can use it as these big membranes that you can kind of place all over the place to help with all sorts of healing. So really, and this is his company, prf.edu. It's also called bioprf.com. He has an amazing 8-hour course. It's all done online that teaches you every single use of PRF possible, including what you can't do in California, but in states like Florida, where if you've heard the term vampire facials, this is the exact same process on where they're injecting this fibrin back into people's faces to get it to tighten up. And dentists can do this in Florida. Maybe that's why he's probably located there. But really, when we're talking about bone and getting it healed, and essentially any healing, whether it be soft tissue or bone, these are kind of the 5 pillars. It's vascularization, getting as much blood in there as possible, with bone cells, with growth factors, and then the extracellular matrix and the biomechanics. What PRF is great at is it's the vascularization. It recruits all of the stuff that helps us heal, all the white blood cells, and essentially gets it in this concentrated form, and you essentially throw it into the body and allow it to work for you. All the research shows with sinus perforations, dry sockets, post-op healing, this significantly helps with patients. So let's talk about just blood supply in general in the jaw. A majority of it comes from the periodontal ligament. The next, it comes from the periosteum. And the last place it comes from is within the bone itself. What are we doing when we're flapping and extracting a tooth? We're removing the first two. We're removing the periodontal ligament, and then if we're flapping it, we're also removing the periosteum. So we're really left with where you get the least amount of bone, the least amount of blood, which is in the bone itself. So why not take all of this extra stuff and put it back in there and allow it to help us with the healing process? So what we're doing is we're separating the the red blood cells and the platelets and the white blood cells, and separating them, those two, by putting it into a centrifuge. And then all of this good stuff, all of these BMP2s, which help with bone, the platelet-derived growth factor, the VEGF, those are all the kind of the biological markers that essentially recruit all of these cells into the area. And if we can concentrate that, because that's what goes into the fibrin, it helps with healing. And essentially, this is what we get. We put this in, and then we get this out. And the most important part to get is this, what's called the buffy coat layer. That's where all the really, really good stuff is. So if you don't get much, make sure you get this, because there's some cases where I can't draw blood. Like I had a patient yesterday, or about a week ago, that came in all tattooed. I couldn't see a vein to save my life. And then there's other people that if they're coming in for an emergency appointment, I always tell patients, if we know we're doing this ahead of time, like drink lots of water so I can see these veins and get it. I'm not the expert at getting phlebotomies done, but a lot of patients aren't coming in well hydrated and kind of are ready to have blood drawn. So I can't get it on everyone, but on those cases that I can, it definitely helps. And like I said, these are the key things. The VEGF, which helps in angiogenesis. The faster you get blood supply growing in that area, the better healing you're going to get. And then some of the other growth factors that occur. And that's why I said BioPRF is a great resource. This is what I was talking about, the horizontal spin. So as it starts to spin, the tubes flare up, and you can get much bigger goobers or boogers that we can then do stuff with. And I think this is a quick video of me just spinning it. And you can see how the centrifuge goes completely horizontal. You can see my office phone ringing in the back. We take these out, and then we're able to we've always put them in a tray. We always want to get a little bit of the red blood cells. That's okay, because we also got the buffy coat, which is where a lot of the nutrients and the stuff that we want goes. And then we can do it three ways. One is there's these little we can put the clots in this little container, and then there's like a little weight, and it turns into these little round segments. We can then put a little plate on this booger and condense it, and then fold it up, and it turns into like these type of membranes. Or we can then cut these boogers up, mix it with our bone, and then it turns into this really sticky bone that you can really kind of condense and get like these condensers and pack it into place. This is a particular case where it's not the greatest picture. Trying to get a sinus perforation picture is not the easiest. But this is a case where I knew there was a high chance of us going through the sinus in this particular case. So we got that tooth out, and there is a decent size, probably a 4 or 5 millimeter size perforation in the sinus right there. So what I did is we took the membrane that we just pushed that in there, mixed up some of that sticky bone, which you just saw on the previous one, and really pushed that. And hopefully we're able to push all of that membrane up and get that to get to a point where we hopefully don't have to do a sinus bump when we get this implant in place. I'm already warning him that there's a good chance we may, but hopefully we can avoid that by getting that all sealed up and getting that to heal properly. And then we kind of suture everything up and then put him on sinus precautions for a couple weeks, and hopefully he doesn't come in with, I feel air coming through my mouth or something like that. So you can see I pushed hard up in that area to try to get that up there as much as I could. So hopefully that's going to be sufficient. That heals nicely and we don't have to do a sinus pump as well. But cases don't always heal that way. So that's why we have what's called the URIS sinus kit. I'm going to kind of rush through this because we're supposed to wrap up and have lunch in about 5 minutes. But we'll walk through all of these protocols. We do some hydraulic pressure with some saline to kind of help push the implant up. The membrane up without perforating it. And then we have a whole bunch of sinus drills that we're going to use as well, that we slowly and carefully kind of push that membrane up out of the way. Different heights, and that entire protocol is set out for you when you're using the URIS system. They have the whole cookbook protocol set up. And then some final drills over here, and then there's some different condensers as well. So we'll walk through all of this. Here's a couple cases that we did, another video where he had some failing root canals, some lesions, and then he also had a wisdom tooth, and we decided to just go ahead and take all 3 of these particular teeth out. Grafted them. This is before I was doing PRP and PRF, so this is kind of how I was doing it a year ago. I'm going to talk about a couple cases that I've done recently. So 5.87, we're good to go as far as the height of the bone. Then they give us that protocol that we talked about, and then all the different steps along the way. So initial osteotomies, then we're going to switch to sinus drills, and when we go to sinus drills, they're not cutting at the apex of that drill. We also want to slow the drill speed down to about 50 to 100. So when we do that today, we're going to have different settings on here. So bear with me when we start using this, because this is not the drill that I use in my office, so I don't know where stuff is. We're going to use the hydraulic pressure to kind of help us aid in lifting that membrane up. And then we may have a perforation, we may not. It's okay. 25% of the time, we're going to perforate, and that's okay. And it's how do we handle that with PRF and things like that to help us get a successful integration of that implant. We're going to put our bone in, and then I've started doing something a little bit differently here at the end. I don't know if that slide is next, but we can definitely, I've had great success with just using the traditional final drills and getting the implant in place. And then remember, the most important thing, so you don't pull a me and get that guide off sleeve offset to 9.5 in this particular case. So another quick live surgery where I am flapping. It takes me a couple minutes to go ahead and flap it. And the first thing I always do before I even get the patient numb is I make sure the guide fits. Just double check yourself. Don't get the patient numb and then try it in, and then all of a sudden the guide fits, and essentially you've wasted you either have to freehand it or you essentially punt and do it a different day. So in this particular case, he had like a little bone spur that I kind of removed real quick. So we're going to go ahead and do the osteotomies here. That's the initial drill. And then osteotomies, and remember these are pretty small osteotomies. We're not going fully to the depth of the sinus. We're about 1 millimeter or 2 short. And this is where there's some wiggle room in this protocol, and you have to feel when you hit the sinus or not. And you're going to see when we get to it in a second, you kind of feel it, and all of a sudden, like, you're going to feel it drop into place where you kind of break through that cortical plate, and you can kind of feel when you're into the sinus and kind of have gotten through that bone. And remember, most, was it Schneidian membranes, it's the membrane of sinus, are usually 2 to 3 millimeters thick, so you have some wiggle room there. And just a reminder, sinus drills, you want to lower the RPM down. You don't want to go full blast in there and rip through there. So nice and slow and steady. And this is where you sometimes have to put a little bit of pressure, because remember, when we're sinus drill, I think this is where you can play with it with the hydraulic. Essentially, we get saline, a 5 millimeter cc syringe of just saline, and we're kind of pushing and trying to move that with hydraulic pressure, move that membrane up to give us to play to get some bone in there. So I'm using Nova bone in this particular case. And you're going to see I push, and I'm not really getting anywhere, and I think I drop here in a second. So I wasn't getting all the way up through the cortical plate. So now I'm going with a 1 millimeter longer sinus drill, and you can see I'm having trouble essentially breaking through, and all of a sudden it kind of like pops in there. More hydraulic pressure with the saline. I'm looking to see if I perforate or not. I haven't. We're going to put bone grafting and material back in. You see me push, and I think my giant hands get out of the way. There, you see how all of a sudden like I pop through, and that's how I know I finally got through the cortical plate. And now, essentially, it's get bone up there so you can get it around the top of the implant. So this particular product looks great. It's a synthetic one, and it looks great on X-ray. You can really see like a difference, so you know where the bone is. And then we're going to do the final drills where we're now just widening the osteotomy to get the proper diameter of the implant in.
Is this the X-ray one you showed last time, or before or after? The sinus?
I will show after coming up. So we're going ahead and putting the implant in. I don't have to worry about the offset being off because it's a 9.5, which is what most of them are. So this is essentially torqued out, but on the driver, and finish it up. And I'm now just trying to like get it right on that mark. So the fully timed part of this also works. I'm gonna kind of skip ahead here since we have to get going. So that's kind of the before. We took an x-ray during the procedure, and you can kind of see the nice hump or halo of bone. That's what we're looking for. The implant's in there. That's kind of the after. So you can kind of see that nice halo of bone around that implant in all the directions. So that's exactly what we're kind of looking for. And that's kind of the after once the restoration's on top, and then the scan, the design, and the final delivery.
Are you tracking how much bone you're putting in?
I don't.
Why do you not think
I take an x-ray. I look for the halo. You're gonna see a case where I probably, you'll see a case, actually this particular case right here. So we're doing bilateral the same day, we're doing 3 and 14. One has very little bone. I think it was this on 3 where I'm pushing the limits on this. And this is where I started to have done things a little bit differently. 1, I'm now adding PRF and doing sticky bone if I can. And 2, if the Densabur system, has anyone ever heard of it? So I'm going, it is a system. Anyways, it's a system where I will use the exact same protocol all the way up to me getting to the sinus. And then these Densaburs, I will still use these at the end, but I will go in, and if you run it forward, it's a traditional osteotomy burr. If you run it in reverse, it takes the bone that it's drilling and essentially shoves it sideways and shoves it up. So it's condensing the bone, but it's also shooting the bone up into the sinus as well. And if you're grafting it, you essentially put the graft in and then put this up underneath and then shoot it up into the sinus to try to get as much bone up there as possible. There's an entire kit that you can use, which I have, which I will show you in a second. You really only need a couple of these, the smaller diameter burrs. You essentially need everything from the 2.7 to 3.2 all the way up to like a 4.3, because that means that burr is fitting through the osteotomy that you've already created, and you're slowly widening it, and all of that millimeter of bone is shooting up into the sinus. And this is kind of just something that I've been playing with and have had fairly good success with it. So it's not something that you need to do, but it's just something I've had success doing. In this particular case, you're gonna see, I didn't have the before, but all of this bone went distal. Like that's a ton of bone. So I essentially was helping them and did a sinus lift for 2 when we eventually need to do 2. And that's one of the downsides with an internal sinus bump is once you get the bone up there, you don't know which way it's going. You're kind of just hoping you get it into the right spot. So in this particular case, we got some where I wanted it to go, but we got a whole bunch where I didn't need it to go. But that's just it's just wherever the flow of that membrane, essentially once you open it up and get it going, where it goes. So in this particular case, you can see I don't have a lot of bone here, and this is where I was probably pushing the limits. And one of the things that I've learned is this didn't have a high enough ISQ to put a traditional healing abutment on, but I asked them to send me the smallest healing abutment possible that was slightly bigger than the implant. So I don't want this implant end up being up in the sinus. So essentially that abutment will hold it in place, and then I suture everything over the top. So that's what I did on the one side. The other side, and this is where we're talking about the Densaburs, so it'll tell you how the diameter of these, and then they have markings all the way along the line. And remember, you have to switch the foot pedal to reverse when you're doing these osteotomies. You put the bone graft in, and then you're essentially pumping it a couple times to get it up into the sinus as much as you can. You really only need like the 3.3 and the 3.5 and the 4.0, because that's going to be smaller than the very last widening of the osteotomy burr that we have in this protocol. That's going to be the left side. You can see all of that bone that we got up in her sinuses. You can see the sinus membrane didn't break. I would have loved to have gotten here, but unfortunately I don't have any control once we put the bone graft in there. Great, and that looks pretty good as well. And now this case is healing. And then we're doing the other side as well, same day, tooth number 14. I have a little bit more bone as well. And remember just the offsets again. I can't stress that enough. This time we had a lot more bone. We didn't have to get as big of a sinus bump. And the ISQs were higher, so I felt more comfortable putting in a traditional healing, custom healing abutment. And kind of this is all day of the surgery after we've done it on kind of what it looks like. So I don't have as gargantuan amounts of bone like I had on the other one, but I think that with the initial stability, the initial ISQ will be very successful. So I hope you all learned some things today on how we can use the kit. I know we're not completely done, but I think the people online are going to be saying goodbye to us soon. For me, it wasn't always easy, but it really started with myself. Is once I decided to make that change, my practice really took off by investing in the technology that we just talked about. And a quote that resonated with me is the only way to make sense of change is to plunge into it, move into it, and enjoy the dance. So I always talk about, that's me falling several years ago. I decided to go bungee jumping when I was younger and more intelligent, as I call it back then. This is in New Zealand. This is where bungee jumping originally started. And my friends and I, we did a semester abroad in Australia, and then we did like a 4 to 6 week road trip in New Zealand beforehand. And we get there, and they are hooking me up, and they're tying your legs together, and it's a very uplifting song of Gangster's Paradise is playing. And he ties me up and he gets me up, and you can't really like walk because your feet are tied together, so you're like slowly like jumping to the edge. And he's like, okay, 5, 4, 3, 2, and he goes, stop, don't jump. And I'm like, are you kidding me right now? He's like, I don't think I double knotted you. He's like, come back. I'm like, okay. So we like hop back, we sit me back down, and he's like, yeah, oops, I forgot. I was like, thanks, man. So I probably should have just walked away at that point and not done it. But I was like, these guys have been doing it for years. I'm unaware of any deaths. And essentially we get back up there, Gangster's Paradise is still playing away. Oh, what happened? There we go. And they actually get it to a point where you get up there and they're like, do you want to touch the water? Do you want to be submerged? Or do you want to like be clear of it? I mean, that's how accurate they got it. And I always say, when I kind of got into this world, you have to take a leap of faith. You have to take a leap of faith with the technology. You have to take a leap of faith with the people that you work with, the products you use. You have to take a leap of faith in yourself. And I think that's usually the part that dentists struggle with the most, is trusting yourself, trusting the technology. The technology is there. The implant systems are there. If you're not doing it, take a leap of faith in yourself, and you can start to have an amazing run and an amazing journey in your practice with a tremendous potential for a lot of growth, especially when you get into that implant space. So I am all done. Let's have lunch, and then we'll start working on the drilling protocols and the hands-on part in about an hour or so. Cool? Yeah.
Just to be sure. Okay, so lunch is outside in the halls. We'll take lunch for an hour and come back for the hands-on portion at 1 p.m.
I think we're missing, was it one that we're missing? Did he leave or is he on his way or? Restroom? Okay, then I'll give him a couple seconds. So essentially there should be 6 implants on your table. Divide them in half and you get, one person gets 3, the other person gets 3. You need at least 1 3.5, 1 4.5, and then 1 5. There is a protocol in here to do a 5 in the regular bone, but we're going to save that 5 for the sinus bump. And then all of the, essentially what I call the onesies, are all offset with the 9.5. Which, if we're talking about 9.5, the offset, that thing that I kept make sure you don't forget about, the one where I always had that gold star, the 9.5 is going to be essentially the smallest one here when you're looking at these guides. If you want to play with it and take that implant out and then try it with the 11 and then the 12.5, essentially the 9.5 is this one, the 11 is the middle one, and then the 12.5 is this one, just so you guys get the feel and how that correlates with the with these essentially the implant placement. Let me wait like another minute, and then I'll probably have you guys come up and gather around and kind of watch me do it here. And if I struggle with these motors, I apologize. I haven't used this system before. There we go. Okay, you guys want to come on all up? So the first one I'm going to do is just the very first page of the drill protocol called the bone block. And we're going to do it with this particular case. So it's D2 bone, so fairly dense. So we may have to go all the way up to the hard bone if we want us to. But essentially, look at this protocol and then kind of find your way across this, and I'll kind of point to the one. We talked about if you want to do a tissue punch, that's your choice. I'm flapping, so I'm going to be skipping this first particular protocol. We will be using it when we do the sinus kit because we don't have the scalpels and stuff to reflect a flap. We're then going to go to the top one, the top drill, and this is essentially just making a dimple into the bone. And this is an old kit, so it's not really going to go by with what the current protocols are. But if you can see, there's the 1, 2, and 3 notches on here, and it's telling us we want to go to the first notch. So I'm just going to go to that first line and make that initial dimple. And then we're going to follow the path drill, and we're just kind of slowly making our way down and widening it. And this is what I talked to you about, where oftentimes they'll have this 3 by 7, so it kind of follows this pathway, and then we're going to jump all the way to the 3 by 7 and kind of go here, and then go 2 by 10, 2 by an 11.5, and then kind of piggyback our way all the way until we're going to be placing a 3.5. So we're going to stop at either 3.0 for normal bone. I might go to 3.4 in this particular case, and then we want to use this smaller platform. So. The presets here real quick. 2 is going to be our essentially most of our work, which is going to be the initial osteotomies. 3 is going to be the actual implant placement. And then 4, in this particular case, is going to be the sinus, for the sinus drills when we get to the sinus drills. So all of these you can kind of customize when we go here. So we're just going to kind of... And since we don't have suction and all this stuff, you're going to see some very non-sanitary suction here. And you just kind of essentially go all the way to the hub, just kind of as far as...
Which drill bit was that?
That was the,
Seven?
this one right here. So you kind of work in this little, like you see the lines, it's almost like a pathway.
Right.
So I'm right,
You're in the power drill.
I'm in the path, what's called the path drill. And then we go to a 2x6. Except, and this is the one time you jump out of the line, is when you go to the 3x7. And this is always like the first main osteotomy. And if you, it says 7, and then if you look sideways, it'll tell you the diameter 3x7 here. And then we're going to work our way up to 2x10. So up to 2x10. And then go up to an 11.5 because we're placing an 11.5. And this is, and then we're going to go up to a 3, and it goes back to a 3x10. And every time I'm doing one of these cases, right behind the patient's head, right behind me is essentially right above this kit is this protocol right here. And if you want to skip some of these, you can. To me, it doesn't take that much longer to do all of them. And then we're going to go, so we have to make that decision. We're already at 3x11.5, so it's a small little implant. So do we want to go to 3x4? If it's really, really dense bone, it's kind of the feel. I'm probably going to go ahead and do that. And you can see it's just a 3x4x10. You're not going all the way down. So I wouldn't be surprised if I do this, it doesn't torque out. Because I think these are set at like 50 to 55% torque newtons. Okay, so so we're going to be talking about the yellow here because this is the narrow that we're doing, the 3.5. So we're going to pick the yellow ones, and there's going to be two essentially implant drivers. One is a hand driver. That's going to go with the torque wrench, which is right there. Or one is going to be a motor. And I'm going to make sure I don't forget. I'm going to switch it over to implant 3, and hopefully this thing doesn't go flying into place. So we'll make sure it's engaged. So usually I stop with the implant handpiece right where those markings, I don't know if it's tough in that light, but you can kind of see like this wave. You'll see like kind of these, there's like where the metal ends. That's where I usually stop with my handpiece. And then I will start torquing it into place. And what we're going to do here is I've kind of asked them to change this slightly. Is yellow, when it's in the mouth, you can tell it's really hard with the light. I'm hoping they change the color or at least get us some different texture to see that. But we're going to essentially get the yellow part to line up to one of these notches at a depth like right here for that 9. So you can see it's already on this diagram. This is what we're aiming for 9. If we wanted to go to the offset of 11.5, we would go, 11, we would go to this line, and then if we're going to 12.5, we're going to that line. But we're going to go to that first line to torque it into. So now that I've done this, you guys probably don't need to go all the way up to the hard bone. You can probably go up to the small. So we're kind of at that line. We have everything not lined up with the notch.
Let me see.
It's tough to tell on these yellow ones, but just look for that notch.
So that notch was 11?
So this right now was 9.5. And that's kind of going off based off of this. So I don't, let me,
I know, I get that, but where are you dropping that to? On a 9.5?
it's easier to tell on this one, but it's like this, not where the U is, but right above that U. That's the 9.5. I wish I had something else besides a pen that's thinner. But essentially right here. This is 9.5. This is 11, and then this top one is 12.5. And that's for the offset.
Why do you keep the guide on when you're at the last moment? Why don't you remove it and you can see clearly better?
Because of the timing. If you don't have this on, you don't know where this is going to line up the hex.
Oh, I see.
And that's where we get to fully timed. And you can see it's pretty accurate, just slightly 0.5 millimeter to 1 millimeter subcrustal. So you could probably eyeball it, but if we're making temporaries, and sometimes the notch they're giving you isn't straight buckle, and I mean it's maybe off slightly, but that's why you need the guide to know where the hex lines up. So if you're doing it with like the Serra Guide 2, this guide kit where we're not worrying about timing, take it off, and yeah, I'll do it free-handed, and I won't have to worry about the timing of it. So I'm going to do, and I guess they do have the protocol where if you guys want to do an 11 offset, you can do this particular protocol. You can essentially take this out real quick and then do it on the 11.5. Just make sure that you go to the second one, and it's labeled here really faintly, but 9.5, 11, and 12.5. So you guys get used to placing at different depths to making sure it works. And then they also have one for the 12.5 too. So I would take these out and then try it and kind of make sure you get used to that offset. I'm actually going to do this one right here. So I'll do an offset of an 11 with the 4.5 by 10. So that's what I'm going to do right now. So we'll go back. We're going to skip the tissue punch one. We're going to go to the flat drill. And you can see when you do an 11, the other thing that gets changed is that first initial flat drill. If you can all see, you're now having to do that initial flat drill down to the second line. And I don't know what kits you have, but this is an older kit they've made some changes to, so I only have 2 lines. So you can kind of see the 11, it goes down to that second line. Ooh.
Yeah, it's wrong.
And then the initial 4 drills are almost always the same with each protocol. Hello. Yeah. We're going to go up to the 3x7. And then we're going to jump up to the 2x10 and 2x11.5. We're going to jump over to 3x10. Something's getting stuck.
Need irrigation.
Yeah, I know. Can I get my suction, guys? we're gonna go up to a 3, 4 by 10. Where did I already, I accidentally just skipped one. So we went up to 3, 9 by 10, and at that point I'm okay with going ahead and placing the implant. So I'm gonna get my 4.5. I'm gonna get that down, and then
Are you doing the sinus first?
no,
The regular one?
yeah.
Okay.
And then we're going to go ahead and put this a little bit deeper because it's the offset here. So that was, right now I'm pretty much at 9, and now I'm going to go a little bit deeper to the 11, and I'm going to line up the black. I'm going to go a little bit more, the black with that spot. I'm looking at this side, but I'm assuming the black lines up with that spot too. So now we have everything timed with the hex. In theory, yeah, about a millimeter subgingival. So I'll be walking around, Jay will be walking around, go ahead and start placing those 2 implants. I would suggest make sure they save that 5 by 10 for the sinus bump. And we'll have some, if you have questions, and I'll come over and kind of show you guys where that line is. And I stole your protocol. So there is one motor between the 2 of you. Please share nicely. Hopefully I don't have to send anyone to the principal today. So remember, 2 is set up for all your osteotomies. 3 is for the actual implant placement. And it's set up pretty high as far as that torque, and I'd say this is maybe D3 quality bone, so I would just do normal bone protocol. Make sure you all have the black kit. Yes, the white kit, it's the sinus bump kit. Yeah?
First, I'm gonna do this one, in 9.5. So I just go to the first line?
Correct.
Okay.
Yeah. So it's number 2 for all your osteotomies. It should be pre-programmed. We tried to do it this morning.
Okay, so I started 2.
Oh, apparently you got switched. So you're 1.
Yeah, so it's like,
No, you got it right.
all right.
10,000.
You be burning stuff.
Did you use this
drill is the top drill?
Yeah.
Does that mean it's too?
It's too flat. Isn't it?
So just go,
It doesn't even touch the bone.
the first one?
Yeah.
Which one are you on? This one?
It's not really creating any osteotomy. It's just
It's more of like a dimple.
yeah, making a little dimple for the.
Is that fully?
Is this 9.5?
Yeah, that one's 9.5.
This is pretty little dimple.
Yeah. That's all you need.
Pretty cool projector, huh?
Yeah, it's funky, but yeah, it works. When you move it back, does it alter the screen? Yes.
Very sensitive.
Yeah, so I was like,
Like if you bump into it, then we're screwed.
okay. I'm glad I didn't. Is it hot or is it just?
I don't know. I did.
Okay. There are. So that's the one when you were talking about keyless, it does add a few more osteotomy sites because they just want to make sure there's no wobble and you start going off.
Oh, that's way better. Compared to the old mobile here. Pylon.
This one stopped myself, right?
That, yes.
A little hard to see, but you want to see a lot, and hopefully that can give you a clear side of it. That's pretty minor action.
So that's the only thing that you have to worry about. Everything else here is just fine. You don't even have to think about it.
So really just, bottom it out. Except for when you get the implant on.
Right, see? Progress already.
Very meticulous, yeah.
Yeah, watching, pro here.
So this jumps.
We jumped into the...
You know what I used to do it by hand. I don't do it. I don't do it.
7 by 3.
I don't do implant with
Perfect.
Really go in very deep.
Until the patient upset.
Good irrigation. Yeah, you can do that.
But my bone is soft and I don't use it. But then if I don't use it, it won't keep going.
Right.
Because of the block part.
Which one did you pick out?
I wouldn't go, when I placed it, I wouldn't go all the way to a 3/4.
Yeah.
It would seem pretty soft.
Right.
Yeah.
Yeah, still.
So I think
But that was pretty, like,
it's modeled after a D2 bone.
yeah.
Okay, I try with that.
Which one did you go up to?
I already finished.
We're here.
Yeah, then it's,
But-
I did it and it didn't torque in very well.
Okay.
So I would probably,
So try with that.
yeah.
Yeah, try without. Then you can really feel the sort.
Yeah, because I thought that this would be too hard.
It's the bottom, I think it's modeled.
Okay, so normal, okay. So now I think this one.
But that's what they said.
That's I have to see. I have to see what I have to see now.
So all you're really, so it wasn't, so you're trying, are we doing an offset of,
9.5.
yeah. So we're gonna get it down to right here.
Oh, okay.
And we wanna make sure the gold is lined up with that indentation. Okay. So you have about another 1.5 millimeters to go.
Yeah, the hand. No, but I think that was.
No, you say you do the machine.
Right, now, yeah, right.
Yeah.
Machine started.
And then
Color
do
the
the
hand.
hand. So.
Is that enough?
To keep it, yeah, if you tweak a little bit, it gets stuck.
Yeah, I would just try to get it.
Yeah, those colors are a little difficult to distinguish.
Yeah, so yeah, right there it was perfect. And it should be, when you take everything off, it should be just subcrestal. See if I talk. See if we do we pass?
This is a test.
Yep.
No.
Okay. So now
That's so difficult to see. So I just go a little deeper. So when that happens,
yeah, for whatever reason, I don't know what happened, but like when I just put it on, it's not down far enough. You're not down all the way to that marking.
Okay.
See how it's still, you still have like another millimeter to go?
Oh my God, this is so difficult to see.
The yellow one is not a great one. We probably, it's much easier to tell with the blue, with the green one.
Okay.
The yellow one is for the mini implants.
Yeah.
Okay. I'm gonna go one more. Can I go a little more? It's so difficult to see that line.
I would do a little.
More? Okay, yeah. Perfect.
Good? Yeah. So make sure the guide is all the way on there. Maybe a smidge deeper because I can see a little bit of metal showing there.
Okay.
But not by much.
Okay.
Like
All right.
maybe
like
a quarter, yeah,
just
a quarter turn or.
As long as this flat surface is
Yeah,
right against
yeah,
it.
you're close. I mean, we're talking about hundreds of a millimeter probably. You have the out, yeah. Flip it so you can go in. What? Yeah, yeah.
So what do you like to suggest is that you engage it right there and then turn the entire thing around and take it off?
Well, mine came out offset.
This is the green one for the green fixture. You need a.
If you're doing the narrow, make sure it's the, yeah.
So it's only two in the go?
There's only two.
Right.
Okay.
So one, in this particular case, it's just a hand driver and then a yeah, fixture driver. A hand piece, yeah.
Oh, there's no.
So these are fixed, right?
So the green ones have an extra ratchet driver.
It has an extra piece that's just designed for 9.5 only.
Right.
Because most of the implants we're going to do are 9.5, so they gave us a separate one that just goes straight to 9.5. That's.
Is this the one? It doesn't have the.
Yes, this is an older kit. They used to have the little.
Right. The silver ring around.
Yeah.
Okay, so
wait, hold on. What are we doing here? So now I'm doing a.
So you're doing a narrow, a 3.5. So the narrows are these two.
And that's only driven by hand?
No, there's one in here.
There's a machine first.
that's 9.5. What about this one?
It's 11.5. You said.
Right.
So that's just for the hand piece. I usually get it down to the first markings, and that's less than 9.5, and then I'll put it down the rest of the way with a hand piece. Yeah.
First marking?
Just put it in the first marking. The first marking gets you to like 6.5 or 7. It doesn't get you to the 9.
The first marking, I can see that marking.
It's tough.
So the first marking on the there's a separate, you see like a silver.
And then,
So at the end of that silver line, we're going to use these drivers. And for this one, the hand piece, and it has these silver markings too. The first line is for the 9.5. The second line is for the 11.5 or 11, and the third line up here is for the 12.
Oh, okay, see.
Damn, you can't even see it, looking at it. Okay.
The green one, the regular, is much easier to determine.
Right,
See.
right.
It's just the kid that
Which mark? I can't even tell.
that we've been using a lot.
So where the markings are on these.
99% of that kit's the same.
That's so first marking is where you want to drive it to for the
I wish they could make it more obvious.
Say that again?
I wish they could make it easier.
Yeah, I know. I've asked.
Right there.
We need a lot of
The second one,
uncertainty there.
top right there. That's 1.5 millimeters above.
The other thing, just real quick, that I forgot to mention, hold on everyone, is that we are putting it about 1 millimeter subcrestal. If we need to profile the bone, there is a bone profiler in here. And it essentially is in the upper left-hand corner. It's one for yellow for narrow and green for regular. So this is what I usually use at the end of my surgeries, real quick. The upper right-hand corner of the kit for the bone profiler. A lot of kits, that comes up separately, that you have to then order a separate piece. They've included it. Bone profiler at the end, once the implant's placed, to make sure we're not hitting bone when we're trying to put tie bases or restorations on.
Like a countersinker.
Yeah, essentially just expand.
Yeah.
I don't know. Yeah, but it's right here. So yellow for the narrow, which is the 3 and the 3.5, and then the green for the 4 upwards diameter.
This is the last.
That's the very last thing that I do. Yeah, and I then will put that back on like normal speed.
Before you place it.
No, after I place the implant. This fits. Yeah, it's guided off the implant. So we're doing yellow?
Yeah.
You already put yellow in?
I put the implant.
Oh.
So it fits over the implant.
It fits right into the implant. Essentially, you just put it in, and it goes down, and it clears off all the bone.
Right.
Oh, got it. Oh, countersink. That's right. Okay. Yeah.
No, on the Nobel. It's called countersinker.
We only do back for these.
Better bone profiler.
I mentioned it. They understand.
The one that I really like is if they want to look at a model, look at the Astra bone profiling kit. Okay. Yeah.
It's interesting is you have a 10 millimeter implant, but you're drilling up to 11.5.
Correct, because you're doing the offset that's 11. So you're essentially, this platform is getting raised by that difference.
To that exact read.
Either way.
Yes, that's exciting.
Sorry, am I?
Yeah, I don't know even it is, but we restart this.
Great. And let me see. You are on the line, and it is matched up.
Yeah, perfect.
And you can take it off and check that when we're done.
Yeah.
It's still a little high.
Which line am I? Right there?
So this particular, it doesn't matter. With the handpiece, you can go all the way up to right here.
Okay.
Yeah, we're going to do the one in the middle, is 11? Yeah, so this one. So the middle one. So this one is the middle?
Yes, 11 is the middle one.
You are on the line.
But the implant is
It's not suppressed.
Put some pink on it.
I'm not sure if it's a guide thing.
So we can keep the tissue covering on it.
Heated properly.
And then the reason why they all say that everything matters, if you're not doing the this is the hex position. And then this is what it
You probably could get another 1/2 millimeter if you're really being picky. Now that I put it back on there and really tightened it.
No, but if I look at this.
Right, you can still go down deeper another 1/2 millimeter.
Yeah, it's always better to be
A little bit deeper than shallow.
than shallow in this kit.
How deep? Like one mil or half a mil?
1 to 1.5.
Yeah, yeah.
Suppressed.
That's all of what I was taught, all the like kind of the new theory is you want to put it about 1 millimeter to 1.5 millimeter subgingival or subcrestal.
So in this case,
That's what.
yeah.
For some reason they have,
There you go.
So now you're equicrestal.
I would say, yeah. Because I mean, if I'm getting 1/2 millimeter here, I need another millimeter. I need another millimeter on this.
Right.
Did you write on?
No, I'm off the millimeter. I figure out why.
I'm thinking either the guide was too high up.
So, this is what I got so far.
So that's with the hand instrument. So that
The handpiece.
the handpiece, this marking is an offset of like 6.
Yeah, so I got that much.
So now you have to go in with
Handpiece, right? With the hand.
the hand torque and get it down to the rest of the way.
It's not engaging.
So you have the narrow.
Oh.
So you need to go ahead and do the green. Don't worry, I did that one too. I made that mistake.
So this is time, if we hear that, then the provision would not fit.
Oh, it'll fit. It's just not.
This may have
Well, for this case, if you see that this happens, you could always go to the roof.
Right. That's not too bad. I mean, it's not on.
Right.
So that's 9.
Because the guide is not.
We use the handpiece to get it down first.
Yeah, so I get it down first and I usually get it just to that marking
The
there.
high marking.
Yeah.
Okay.
And then I take the hand ratchet from there.
Right up here. Yeah, that first one's in depth. Yeah, there's like a little mark.
right here?
Yeah, he's doing it fingernail.
You know, it's hard learning this.
Yeah, I feel as I go along, I got this all through. I gotta have it stacked.
Each of those notches is a difference of 1 dimension.
It's not bad. Jesus. It's a lot easier than I was expecting to see this in the mouth.
Remember, if you're doing a yellow one, it's probably going to be in the front. You're probably doing in a lateral. So it's going to be a little bit easier. When we're talking about the green, we're going to be in the back and it's a lot easier to see. think
I'm lined up already, right? Does that look okay?
I would still go another couple turns.
Did you go through
You were just going.
full,
Oh, I didn't go to 3
okay. Wow.
Surgery like this, and then they just come in the driver's side. And then that's much more painful.
So you.
I didn't go all the way. I didn't go all the way. I went all the way down on the guy.
So you just went to. Hold on. These guys aren't fitting great. There's a, make sure you're like.
Alright, so this guy.
Yeah, so if you're a little off,
Did it end where it's supposed to end?
you go like 1 millimeter off.
Just goes directly.
Yep, and just go to town. I would go with the higher preset.
It would be all the way down here, but it would have a stop.
Exactly.
I mean, I can't keep going.
You can't do it. Essentially, it's designed so it won't do any damage to the implant. Oh.
Something that I never really had in terms of now I use it. Can touch it. Yeah.
Because if I'm off, it's short.
Yeah, you will. Almost all of the drills, the osteotomy drills, are actually a millimeter longer than you think. So you won't bottom out. You still have room to go.
Okay, yeah, that's what I'm afraid of. Like, yeah, even if I crank this a little bit more, I look at
No, you'll have
a
room.
millimeter short.
Yeah, you'll be
I
fine.
can crank it all the way down. You know.
Before you start stripping the bone and get a
Yeah, so it gets spinner.
yeah spinner. My favorite.
Yeah, my favorite too.
Well, you have half a millimeter.
So how do you read this? It's from the top down or from the bottom up?
Bottom up.
The first dots are here.
This is down to the 11.
To get that, it's way above that. It's supposed to end right there, right?
You're I'd say maybe a half a turn more to get to 11.
Okay, half a turn.
Pretty much. I mean,
Yeah, so I don't think that's
yeah. So it wasn't. If I added the first one, I mean, it's like yours.
well, that's never asked me to sure that is.
Right.
You know what I mean? Yeah.
Don't be as accurate as
Perfect.
It's good to know it's an elevator kind of.
I think it was catching it.
Could be.
That's great.
Storm, just show up for lunch and then leave.
Yeah. He does ask. He probably came by to say hi to you.
Oh, make me feel better.
Looks like we're on schedule, right?
Should be, yeah.
Yeah.
2.
We're thinking about finishing around 3.
Yeah. I was going to give them about 5 or 10 more minutes and then.
Go to sinus?
Yeah.
Okay.
In the moment of truth.
So you're not, that stop is actually not using it, right? You're supposed to stop at 25 millimeters before the stop. For that one. That one is the one.
I'm going to give you guys about 5 or 10 more minutes. So if I would start placing your second one if you haven't already.
That one is kind of a.
And we'll kind of come up and do the sinus. What? About that? Yeah.
That's why I think that there's a
Wow. Damn, look at that, boys and girls.
That might actually be hitting there.
You should not hit the bone with that. You don't want to bottom. Is that your first?
Yeah, this is my. Well, we're trying to figure out why. This is a flat drill. So the flat drill on this one here on the.
So this is an older kit, so it doesn't have the 3 lines and
Right, I
lines
would
too.
go to the second line, right?
If you're doing an 11, I would do the second line.
Yeah, but the thing is,
Yeah.
before I even hit that second,
Okay.
that's what we're trying to figure out where the discrepancy is. It's probably in
Yeah.
this. Before I hit it.
And the rest of it, we handle with.
It's a middle.
It's probably why you didn't hit it on the first time either. Yeah.
It's set at 68 and it won't go down below 77, right?
I think we keep my office at like 66.
Oh, really? Wow.
Just because.
Do you get easily?
Yeah. Well, I have 2 hygienists that are going through menopause right now, and they're like if I set it a degree higher, they're like, ah!
I versus complains anything higher.
Work with this motor, NSK motor in the future?
Doesn't matter. It's weird that it doesn't have a torque value that you can select.
Yeah. I noticed that.
So I think the reason it's not working in and stuff is because it's not, the osteotomy is not wide enough. Right, it's for the 8.5 diameter and narrow.
This is standard.
Okay, the 5.6.
No, but this is green.
So green doesn't. So green, yeah, you're using a 5, but you only made osteotomies up to.
Still 5 too?
It can be 4, 4.5, 5, 5.5 are all green.
All green.
It's for restorative purposes. Get your muscles.
They didn't put a 3 here. This is 3 by 6.
Because these ones should have been.
Yeah, but this is
More.
I'm glad there's no patient.
This is where we have the practice, exactly.
I'm going to steal this from you, and I'm also going to steal this from you, because I need this in a second. I'm also going to steal this from you.
Let me see it. Let me get you
So yeah. So it's restoratively, green's all the same. So same restorative components. So 4, 4.5, 5, 5.5.
Restoratively, all the same platform.
Correct. So it's the platform is regular. It's the diameter of the implant.
Figure out why would you make it the same color?
Because restoratively it's the same.
Right. No, I get it.
Yeah. Okay. Which I like, because that means I don't have to have for every single diameter. I don't have to have different restorative pieces. I only have to have 2.
Right. That makes sense. Yeah. Because I was the well, I have to have
right, different sizes. Yeah. But you also have different sizes that go along. Yeah. Yeah.
That's the only problem. Potentially, if you just look at the color, it's with the wrong diameter.
Has everyone got their 2 implants in? No? Okay. 2 or 3 more minutes. What?
On to sinus. Forward.
Do we use these drivers or CBCT?
Nope. When we're talking about green, we're going to the 4 and above diameter.
Switch to green.
And this is 9.5, this is 11, that's.
No. No, these are all variable.
So, how
So the one is just handpiece driven, and then one is hand driven.
so which one's handpiece?
That one right there.
How far do I go on this one?
So that one, I always, not to the top, I always go to the silver marking. I think it's like 6.5. I have a slide.
How do you, how do you make sure it's not gonna hit the implant?
Just removing what is on top. So it doesn't have any extra indicator, so it doesn't engage with the implant. So it doesn't all the one that is on the inside.
This one right. So with the handpiece driver, that line is taking you to 6.5. If you want to go all the way to 9.5, you're going all the way up here.
But if I'm using 11 and a half,
The offset's 11.5.
offset's 11.
Then you can do, it's your choice. You can either put it in with the handpiece here or here, and then hand torque it the rest of the way. So then you get up to this line right here, which is the now 11. When you go to the yeah. And the newer kits, there's this little platform here that will actually, if it's a 9.5, will stop you at 9.5, where you can just essentially sync it without looking until you want to get it the hex lined up. Then you stop.
So that was what I was saying. There is a stopper, but if you're hand torquing it, or gives enough force for you to overpass the so you have to usually rely on the
I can see my implant there.
So how about this? That's different from this one here. This would be.
When you're feeling confident.
Okay, so this one is basically down there on the left side. See, this one has this part.
Do we want to give everybody 5 more minutes?
So I can.
Sure. Then it'll cut off and I can answer any questions.
Okay, so then I would switch to this.
Correct.
And this first notch is that's.
Yep.
So it's
What's the consequence of just being a little bit off, either right, lining up to these things, or a little bit below?
So below, not much.
Okay.
There's no consequence of it, really. If you have something prefabricated and you're off, then that whole.
Talk about that minuscule.
Yeah, then you should be fine.
Should be fine.
Yeah, but if you have like a full contour restoration, then that angular, it could be off.
Okay.
So if I'm off, then just torque it a little bit deeper. I'd rather go deeper and have that lined up rather than that angle be off.
You can correct that later? Why not? Right? When the restoration comes in, it's already...
Right, so well then once this is placed, you're taking another final impression to correct for that. But if you have anything pre-made, especially full contour restorations, that's going to be off.
anything above 74 I explode. No, it's okay. I got to. Business platform for sales or marketing. So, whatever your.
This is supposed to take. Oh, this one is a picture, but this one is just, it doesn't get to go.
One is
Okay, so
So, like, yeah, if you don't mind, I'm happy.
How much wood we have right here?
This one will work.
You said the same implant.
This one is your,
Is this the old style kit or is it the new style?
That's the older, it's an older version.
Is the older version?
Because the newer version, what it also has is it can also be used as free-handed. So all of these numbers, so like a 2 by 9 or 2 by 7. There's a mark on there. See that white mark? That's the 7. So you know if you get it to that point, that's the 7. And essentially the difference between the line up to the hub is the offset. So you can do it both ways.
So they all have the laser line.
Yes, and then you'll see it also has this like little like notch in here as well.
Am I there?
Yes. All right.
All right, let's start wrapping up. Because I think some of you want to get out of here too. So if you guys want to come on up and we'll start doing the sinus kit. And you guys can continue playing with it, but for those of you that want to get out of here and go enjoy your weekend, please kind of respect everyone's time to come on up so we can do it. You guys can definitely go back and I'll be here to do it. All right, so you guys really have your choices of which implant and sinus bump you want to do. There's essentially 2 different guides and they've both fit this model. So if you want to do 2 and 3, you can do 2 and 3. If you want to do 14 and 15, you can have a model, or if you guys both want to figure out who wants to do what. In this particular case, I'm going to do tooth number 14. This implant is a 5 by 10, and the offset's going to be a 9.5 for this particular case that I'm going to do. So, tissue punch I already did. So we did the tissue punch already when you guys were sitting down there. I stole some of the instruments for you, so if you're missing something, let me know. And then this is our lovely bone. So tissue punch is done. And we're just going to kind of follow this protocol here real quick with the top drill. And I'm on the right set, so we're just going to go ahead. And it really doesn't take much. I think that I hardly even touched at all. We're now going to go to the 2 by 2, and we're going to go to the 2 by 2, the 2 by 12, excuse me. And you can kind of see on the kit it says 2 by L12. And we're going to just go ahead and kind of go to complete depth with that. Make sure the guide's on there nice and tight. We're going to go up to 2.7, length 12, and we're going to essentially go to depth again, and we're going full speed here, and then the next step is where I'm going to tone it down a little bit. So this is getting us to about 1 millimeter short of the sinus and the best of their ability based off the CBC data that we have. I'm going to go ahead and hit preset 4, which is going to take it down to 50 RPM. And this is where now all the way moving forward, all these are not end cutting. So you can kind of really feel the difference when you start playing with these. We're going to go to a 13, 3-2, and we've slowed it down. And this time, like I said, this is where you actually have to put some pressure on it, because you're essentially trying to just force and break through that cortical plate into the sinus. And this is when we'll get this out, I just took literally water from my water bottle and kind of put it in here. And then we suck it up. And it's going to tell you how many cc's. You were asking me earlier how much cc's put in there. It'll kind of give you an estimate of how much you think it needs to go in there. So we're going to, you can put this on a snazzy little handle if you want to. Usually I just hold this with my hand. And through the guide, we're going to put this all the way down as snug as we can. And we're just going to put, and you can feel kind of the pressure here. And we're going to try to get, like I said, maybe a half to 1 cc in there, and then we want to pull that back to get that fluid out of there. And if we see blood coming out of here, that's completely normal. Not today, but with patience. So this is then where I will oftentimes just check and see if we've gone too deep. I'd rather just take a couple extra seconds.
Does that ever leak water around the
It can.
fixture?
Yeah. So you can tell now when I actually put the guy down, I'm like right there. So I'm going to go do the next step, which is kind of the 14, which is we're going to start
Cortical plate is broken.
Yeah. And oftentimes you'll like, if you push it with these, you'll put some pressure on, like I saw in that video, you'll like pop through, and that's usually when I know that we're there. You can see some of the water coming out.
Do you ever try to pop through first before you do the water?
You can. Just what you're also, popping through is fine, but that pressure is trying to separate the bone and the membrane to get some space so you can pack bone in there without tearing the membrane.
If you're not through that cortical plate.
So you don't, we're not going to go through it, correct.
Or will it force itself up through the...
It could, it'll probably leak and you probably don't know.
Can you feel the difference when you're through on that thing?
I haven't.
Yeah.
I haven't. So I'm kind of just keeping my eye on. So like now it's a lot different. I guess now with this particular one, we'll see if I tore through it or not. There's water coming out the bottom. But I can kind of feel the difference with that. There wasn't as much pressure there. Or much resistance. So, and then sometimes I'll even go up. That's a big jump from an L9 to an L12. I'm probably not going to do that, but I'm going to start. Was there a this is why I like.
Nice.
Anyways, that's why I like the Nova bone. Yeah.
Is it not getting a C?
No, yeah, there's no bone. Is there a bone carrier here?
Yeah. Kind of. I think
I saw one out there somewhere.
here. You could do this. Or
No, that's not.
No, the amalgam carrier?
There was an amalgam carrier I saw on someone's desk. But you get what I'm trying to do where we're packing bone.
Maybe this?
There we go. I don't know if this is going to work anyways either.
Hey.
Better.
I still have that in the office.
I do.
But this, when I was talking about the densiburs, this is where I usually then bring in the densiburs and do some smaller diameters to try to force the bone out and then up after the growth. At this stage right now.
Did you say you're routinely using a PRF?
What?
Are you
Yeah.
routinely using it?
Yeah. If I can get it, I'm doing it. So
stuffing PRF?
I would stuff PRF first, then bone afterwards. And then if I have some left over, I'm going to put that over the top of the implant. Sometimes I'll cut it and create like a little hole and then put the healing abutment through that little hole and then suturing everything up. But yeah, this is where I would be using PRF. So we're kind of at this stage right now, and then we're going to go to the two final drills, which is a 3-9 and then a 4-3. And these are like completely flat. We're going to keep it on the sinus drill I think I just picked up all my bone graft.
That happens in real patient too, right?
Yeah. Yeah. All that bone graft that I just put in there is now
Sorry, what are the point of these last burrs?
to widen the osteotomy to get your 5 millimeter diameter implant in there.
I put a drum implant.
So these are only widening it up to 3.2. We're going all the way up to 5. So we need to start widening the osteotomy as well.
Okay. But I'm thinking, why not widen it all the way first and then come back and add your bone and your PRF and then go ahead and stuff the implant out? You're not getting more extra length, you're just getting width.
Correct. That's the protocol that they've created. I don't know if I'm using the Densibur, I want to have some of that bone around there, a smaller initial osteotomy to essentially shoot more native bone, more autogenous bone up in that spot.
But I'd be afraid I might catch my PRF or whatever.
Well, these are flat, so it's not going to cut anything.
Yeah, if it's not through all the way, if it's like kind of
up on there.
Of the osteotomy, you're gonna,
like you're on the side here.
The worst case scenario is you shred it and push it in, right?
That's
what you can pull it out. You can pull it straight out. We gotta get caught up on this flutes on this and then just kind of pull out.
I mean, I don't think you're going to.
Even on the sides? I'm just saying, this is the way it comes back from the lab, right?
Yeah.
But you're pulling out, Robert.
Yeah, I'm following the protocol at that one. All right, so then we're going to go ahead. I'm going to set it for implant placement. In this particular kit, there's no narrow. I don't think anyone's doing a narrow for a sinus bump. We're going to have enough width to get a decent size, at least a 4, 4.5, or 5. In this particular case, we're going to do a 5. So green with green. Four, 3. And we're going to go up to that mount where it's usually 6.5, and then switch over to this one and get it down to 9.5. I'm running into the guide a little bit, so what the next step is to get this extender. So now I'm not hitting the guide. And they have extenders for both the osteotomies and also for the hand torquing. And we're right about there. And then what I do, it also comes. This one doesn't have the bone profiler kit in it, so I will often, it's a 9.5. So I will often have this kit handy when I'm doing these cases.
Are there extenders in that kit as well?
Yeah.
There's extenders over here.
Okay.
I'm upside down, so then I will get this in. And do my bone profiling real quick. And then the moment of truth. Cool. Woohoo! I get my CEs. Jay, you hear me?
Yes. No. Yeah. Okay. Turn.
Oh, nice.
And then if we want to see and double check that we did get all the way down to depth, because we can't tell with doing a tissue punch, we rip it off and see if we go down to depth.
Yes. I used to because I had somebody to do the glue.
Aha.
Hello, guys.
Right there. So right about a millimeter. So good luck. Oh, I stole stuff from some of you. I think I stole this from you. I stole that from you. If you need bone, good luck with the Rice Krispie treats. Yes.
Yeah.
And then if you need water, bottled water.
I don't care what size, the first size.
And just make sure you're going off the right protocols. You're using the right implants because there are 2 different guides. There's 14 and 15, and then there's also 2 and 3.
Okay, this is my first time.
And if you perf the membrane, welcome to the club. You will do it sooner rather than later.
It's a 20% chance or 10?
25, they said.
Damn.
That's what the research shows. You can't fit both guides on at the same time. You're going to have to do one at a time. And this is your, I think, I stole yours. Anyway, I also have this. I stole this from you too.
Oh, that's the kit.
Yeah. Yeah. He was about to.
Thank you.
The moment of truth. Oh.
Right.
Settings, I think we did two. 2 is normal osteotomies, 3 is implant placement, 4 is sinustral.
So you're gonna be at
4 for once you get to the sinistrals, essentially here over is sinistrals, and that should be 50 to anywhere from 50 to 100 RPM.
It's always good. Yeah.
As soon as you get to this one's a little sharp because we're trying to break through the cortical.
It's still cutting, I think.
Oh, so it's still end cutting.
This one doesn't feel like it's in the right spot. It is.
That's not cutting. That's too cutting. You can feel
These are supposed to be not end cutting, but these, yeah.
That's what I thought he said. He said
Yeah.
the line is not
Really?
end cutting.
From this over, you can. It's not as sharp as these.
Okay. Hey, I say it's cutting. You should use your finger.
So I don't go all the way down?
Alright, so.
You're gonna have to put some pressure on it. There you go.
Still at high RPM?
No, which one? That's high RPM.
And then you walk.
So that's your, it's in the same day.
So this will start looking at offsets already, the 3 notches, offset.
No.
Stop at the first one?
Yeah, and it'll show you on like the diagram
Right.
where it wants you to stop.
It's already there.
Then you're fine.
Okay.
Sometimes it just. That one really doesn't matter because you can't really go too far deep.
Is it the same, right? This wasn't the kit.
Yes, some of them will be in the kit. That was far and few between. I didn't see them on every table.
Let's see, let's use that one, I guess.
So you want to look at, yeah, put it as far down as you can. Get some with the guy. Ooh. And then you're essentially looking at their recommendations. So you're looking about a little bit less than a cc of kind of pressure, if you can get pressure.
Usually it's like 0.4 at the beginning, like the high osteotomy.
It's okay, it's fine. It might be leaking. This is kind of just a feel, and sometimes it works, sometimes it doesn't.
It's a model.
And in the mouth, I've had patients all of a sudden they're like, "What's that pressure?" I've had other patients not flinch at all. Sometimes I do, sometimes I don't. That one's it's really been a 50-50 split on that.
When does the drill slow down to 4? Is it the final drill?
As soon as you hit here, where it says sinus drill over, that's when you get down. Sometimes I was just telling you, sometimes you feel it, sometimes the patient will all of a sudden flinch, sometimes nothing happens at all.
If you feel too much resistance, then you want to go
Like, I don't know if you noticed the first time I did it, there was like, I couldn't press, like it was a lot of resistance, and the second time I did it, it just started coming out. That was kind of when I was breaking through. I know. Have you actually seen anyone perf it?
What?
Has anyone perfed it?
A few, yeah. I did it.
Oh.
So you say if I feel too much resistance, then I can go back to 14? Yeah, 14 and then I'll do this again. If you feel too much of pressure. But I'm going to go 14 anyway. Yeah. No. And then just go back. Yeah. But you have to do it already. So that's yeah, no. So I'm going to follow. Yeah, this is our plan case already.
You can. That's why I like the Nova Bone that you saw me using, because it comes in like a cartridge and I can get it in there and put a little bit more pressure, but then I'll still condense it. Or then I'll go in and do the Versa drills or the Densiburs and kind of get even more up there.
So in this moment, after the condensing, you would use the other burrs?
Yes, at this point. I'm still kind of playing around with it, but in those two particular cases, it worked fairly well. And then before I pack the bone, if I'm doing PRF, I'm putting the membrane up there, the membrane up in there.
Oh yeah. Let's see.
So four for the bone.
I'm gonna borrow it.
We have two, right? Once we condense everything and then go through. I don't feel like it's through. Oh, I see.
No, because this doesn't really condense anything in there.
It doesn't engage.
Then I would go ahead. Did you? Sometimes I've gone up to I've gone up to from a 13 to a 14 to a 15.
I told them to go low because you may make mistakes.
So you would go up to
Until I feel that breakthrough, I often will keep going up. So I've gone up to a two or three.
Yeah, depends.
Yeah. This is where it's just kind of a feel.
You have to push a lot.
You do.
So go up to the 15 now?
Yeah. And then don't blame me if you perfed it.
This is for the multi-unit abutment, and then this is for the whole abutment, and no one can see this thing to be honest. Yeah. And then this is for the whole.
I bet you, yeah.
Yeah, it's
I'm supposed to go the way down.
Which one is this?
The last one.
Yep.
I had to go all the way to here.
Yeah. But you can go back up to your.
Oh. Previous one, the one.
So that's where you might not have actually broken through at the beginning.
But I felt it.
Okay.
I felt when it went.
Benchtop experience on it.
So what I would do is take this off and now condense it.
I feel it.
Okay. Ooh.
Looks like you're there.
Yeah. I'm very close, but not all the way down. You don't use like a.
You could at this point.
Could it be that I put too much bone?
Maybe.
Let's do genome
Or just go back up to see if you go wider. Just try that and see. This is where it just. No. Try it now.
But you felt it, right?
I had to press a little bit harder and then it kind of, oh, hold on.
You good? Yeah.
Oh, thank you.
Are you using the document skill or not using the
water? I guess I need to have someone explain the water better.
You're there now. I just pushed really hard.
So for the final drill, you always want to be at 50 to 100.
Yeah.
50 to 100 RPM.
I'm sorry.
50 to 100 RPM.
50 to
Yeah.
100 RPM. You're like at.
Yeah, I know. We were
Now 4, right?
to put the implant in?
Oh. I thought I was going to go this for the last time.
Oh, go for it.
I'll try my best.
Maybe for the first time.
There you go.
I do always use. Yeah, you feel it and realize how it is.
You don't want this stopper to engage with the
goes here, right? So since you went to L16, you want to go this one.
It kind of doesn't show. One more. So in this case, because it's at the very top, I'm gonna like notch, right? So you want to align. So you want to align this top part. Yeah, that notch. Yeah, with this like on that's the one with the stopper. Okay, so you want to
You went too far? It's okay.
These are all 9.5?
No. This one right here, you can go all the way up to.
Is that better?
No, you still could go deeper.
Oh, I thought it was too deep.
So you're going all the way up to, so you don't see any metal anymore.
Oh, the black line?
Like right there.
The implant's too high up.
Okay, let me see. So this is why I like to do flaps, so we can see it. But let me. So yeah, but you're not there yet. You're still about a millimeter.
On top of
yeah.
Okay. All right.
So we're getting these like packaged.
It dropped in.
Oh, it dropped in?
Yeah.
No. If I order the guide, is that an option? Yeah, it's extra. Is it extra?
Yeah. Number one, right?
Number one is osteotomy.
Yeah,
So just go to stuff.
Yeah. So either the model's off, the guide's off.
Okay.
I mean, these are all mass produced.
Okay. That's
But
the idea. All right.
so that's where we then make a decision. We kind of have to do some
With the flap, and we know to go down.
flat, right? Essentially, take another turn or two, go a little deeper, but we still have make the line lined up.
Thank you. Is it always true clinically? There's a little give when you do this?
You go back
You're
and
lining up? Because it goes like this. But
I always go to like torque it and then stop where like you feel the pressure.
that's where you just line up.
You're right, there is a little give.
Right.
I don't think it would be like that in the mouth.
Okay.
I think also these kits have been used several times now.
Yeah, this is not very relevant.
Yeah, remember this is a fake plastic model that they're trying to make.
Yeah. Even in the if you do like too much rotation when the screw doesn't go. And then you can also always check. Can you get the tissue?
Sort of good.
I would go for 5 upstairs.
And just line up the edge work.
This one is the temporary or
Okay.
We survived over here. We didn't.
Yeah. I think it did. Yeah.
What?
It improved.
Be a lot more better than I thought.
It's pretty good. So basically it's going like this.
So like I would just start off with 50. Yeah. Like I would just do everything low-key because sometimes like you pick up something else and then you use sinus to with like $1,000. That becomes an issue. You're an engineer.
You. Oh. Oops, sorry. So you only do that once when you're putting the implant in and you forgot to put it to implant mode. Zoom. Did you look? Did you pass? See, this is why I love flapping. Flap!
Keep it though.
Flap it!
Hey, all right. I know.
Also, I mean, I think about it.
We got a funky one. He said, put it on that.
Okay, so yeah.
I think it's, you had the same issue, right? Yeah. I think it's something with your handpiece.
Yeah. Maybe it's our drill.
Yeah, I think it's the handpiece. Not your fault.
Yeah, if you got grind bits inside.
Or here, use mine. I don't need it. Here, son.
Start with 6? Yes. And then finish up with 9? Yes. There we go. Okay, now, 6 would be the exact same as the...
Right, that's why it's initial. Kind of like stuck.
And now we're talking.
We cannot
You don't pack it?
Yeah, what does it sound like? The chisel technique. What you're saying is if it's 6 millimeters range of at the bone, then we're not.
Right, because if you start with 9, you might get
So the amount of bone that we packed in, it's all should be soft tissue, you can randomly give me ways to actually have everything. Way too much bone here. But if it's an actual practice, you have to pack the whole amount that is just packed until it's gone, okay? Okay, now I place it here. Okay, now I use this one. And we're going to go to the yellow and silver.
No, I think you did.
Oh, they stole it. Those are the thieves.
They took everything from us.
I just did. You want to switch? You want to switch to 50? Space and kind of like making a
If it's less than 5 millimeters, they say it's okay.
There's really on sinus protocol and you're still missing. They get it.
Right. So assuming the sinus is a little lifted.
Do you sedate?
Not on these cases.
Unless it's like a big cases, you probably don't.
Yeah, that's for the 6. And for the kit, which is the new kit, the kit we have is there's 17. So it's kind of like all in one.
That's too short.
When it comes to
That means
Fancy. Woo! You got some bone in there. They may not need a lateral sinus lift on 15 like my case. They got a free sinus lift.
This way?
So if you use a vial,
long day, huh?
you're doing like all on 4.
I've seen like other doctors. I don't do all on 4s yet, but it can be done. They have classes here that teach you that.
If you use this part here, make sure you like do maybe like one round and stop maybe for like 10-15 seconds for the bone to like kind of like cool down. Otherwise, if you do like too fast, it might bone necrosis.
Believe it or not, URIS
And really, any implant now out there can do it all on X. Okay. There you go.
Look at that, with the bone and everything covered up.
Nice. No sinus purse yet. Don't jinx it. Who's next?
You don't fail the course.
Where's the other one? Did you check his? Did you check his workout?
Oh, yeah.
Oh, you both passed. Who did? Yeah, who did 14?
He was the first one. He was the first
Squeezed
one.
it in there.
What would happen if we offer monetary
Compensation?
compensation for not perfect?
person that purrs has to buy drinks for everyone.
Are we done? We are.
We're done.
We're missing one piece here.
Is it in the handpiece?
No, that's fair.
Are we good?
Yep.
I said a driver's permit.
The very good tip.
You guys have any other? Do you have any all? He was asking about all in X's. Any all in X courses with Frankie?
Yeah. Well, all the next courses on Frankie's course. He just sometimes does it here.
Okay.
Yeah. So he does it in his lab. He's set up with all the certain with
I think this.
No.
Those are expensive. They'll probably reuse them.
Oh, you reuse it?
They're like a couple grand, like grand.
They're about 700.
Yeah, they're.
I was gonna show my thing.
Is that crazy?
Like I've done one sinus bump before.
Hey, this whole hands-on course was free.
Yeah, don't take the model home.
Please don't take them all home. Yeah.
Certificate.
$700 per model.
Are you going to pricing it on that?
Yeah, if you're interested. So, can I get 30 seconds of your time? So just so that everybody knows, if you guys are interested, the package that you guys have is the $5,000 package. It includes the Pylon kit or the sinus kit, 10 implants, 10 healing abutments, 4 scan bodies, and your first unit case for free. So if you guys are curious how it works, it's basically a form. Once you log on, it's a la carte. So you just click on different things that you want. Like if you want the implant with the dye, custom healing abutment, custom abutment, so on and so forth. And so your first single unit case will be free. So that's the package you guys have. If you want the non-guided kit, I don't know why you would, but if you do and you want to do freehand, it's $1,000 for the same package.
Well, are you saying that the guided kit and the kit is $5,000?
No, it's separate. So you get one kit, 10 implants, 10 healing abutments, 4
For guided doing standard.
Oh?
For guided.
Oh, sorry. The healing abutment is not included, but the fact it's guided.
I do know the package first.
We can work it out.
That comes out of my bonus.
That's great, yeah.
That will come out of my paycheck, so if you guys want to push for that.
What about the sinus?
For the water.
Same thing.
We
It's the
don't
same
care.
$5,000 package. If you want to get the sinus and the guided kit together, they'll work out a
I
package.
like the photograph too. That's
Yeah, we're looking more.
And you know, the last time.
I already got half. I already paid half.
But it's a good deal.
I already got a little.
oh wow, that was great.
And if you guys are, just a reminder, if you have a CEREC machine and want to learn how to restore implants with the CEREC using the True Abutment system, that class is with Dr. Hagen, who was kind of poked his head in at lunch, September 17th. Same kind of concept, morning lecture and then hands-on in the
We
afternoon.
have all the CERT software over there, so you guys could get hands-on, design cases.
To play for free. So
Yeah? All the courses this year is free.
September 17th.
Yeah. But even if you don't have it, you're interested, you'll be fine.
Yeah, I just want to tell us.
Yes. And I will probably be here doing the hands-on.
Yeah, I was
Dancing alone after using that almost as like that's really good.
I was close to the body.
Nope, CEREC has no money. Well,
Sarah Club.
the CEREC Club, which is the warranty, that's the fee.
Oh, the upgraded software.
You can quit it afterwards, but if there's anything ever wrong with it, something breaks, they'll come out and replace anything for free. And you can go up to, I think, 6 years is how long they offer it. I think. Not bad, 304.
Yeah? We're on schedule, right? Not a lot of times you can say that. How's the hands-on section today?
It's good.
You were the first doctor that did our first hands-on for our.
Oh, when I way back when?
One-on-one.
Yeah.
Any lectures after?
Today?
Yeah, or is it done?
I'm done.
Okay, then we gotta get the have Katie prepare stuff. for
Oh, yes.
after hour.
Happy hour? Yes, we're done.
So, we'll if you guys want to hang out, I think the law is I get in trouble.
Yeah.
But yeah, you guys can hang out. We'll have finger food and drinks and.
That's where the fun happens.
Yeah.
And the fun questions come out, the real questions.
It is a Korean country, right?
Yes.
That's soju on.
Soju and height?
We do have a lot of Koreans in this company.
No.
It's not a Korean company.
Here too,
Is height on draft somewhere?
It's not a quote unquote Korean company, but we do have a lot of Koreans.
People got mics and stuff.
Yeah,
During COVID.
You did? You rode your bikes here?
What do you guys think?
You're welcome. Thank you.
So we'll have drinks outside in 10 minutes. We'll just get that set up. And then food will be here in like 25-30 minutes. So,
Okay.
So if you guys want
So continue lecturing?
Yeah.
if you want.
Yeah.
So what's your sinus protocol that you put them on if you perf? Or when you perf?
Yeah, when you perf, just Augmentin and then, or Keflex if they're allergic to it. And then just try to be really careful with.
Do you nasally decongest?
I don't.
I don't know. So I'm not a doctor, so
Yeah.
I'm not gonna say.
Go ahead.
But usually class 1s are not really a big deal.
Right.
Yeah, they're minimal.
Yeah. And that's what we just did. We're not making a hole bigger than 5 millimeters. So that's, and then these are not sedated cases, just local anesthetic.
What do you guys think?
Now we just have to get a life. Now we have to do. We have to get life patients for them next.
Oh yeah. We're actually planning to do that next year. It's just we have to just legal people.
It's so much legal work.